Good afternoon, everyone. I'm Dr. Shweta Mittal Gupta, convener for the IUI workshop, along with Dr. Neeti Tiwari and Dr. Kavita Agarwal, co-conveners for the workshop. We extend our greetings from team IVF, Gangaram Hospital, and AOGD. Now, the theme of this workshop is revisiting IUI in the era of IVF. A very small saying that I can always have new learning, and when I have this new learning, I can make new thoughts. It's very important. We know that every now and then we hear many IVF centers opening up, but what we feel is that if your basics are strong and if you have an optimal success by starting off from IUI, then you can actually build a great IVF practice. I welcome you all, and now I would request Dr. Mala Srivastav, who's the president of AOGD, to say a few words and open this workshop.
Thanks, Dr. Shweta. Good afternoon, everyone. On behalf of the organizing committee of 42nd Annual Conference of AOGD and first e-conference, it is my privilege to workshop on revisiting IUI in the era of IVF, nicely organized by Dr. Shweta Mittal Gupta together with Dr. Neeti Tiwari and Kavita Agarwal under the overall guidance of Dr. Abha Mazumdar. The program is nicely crafted and planned to touch every aspect of starting from the basics. Best is the panel discussion on case-based scenario in ovarian stimulation on IUI. I'm sure all the PG students and young buddy delegates will highly benefit from today's e-conclave. I wish today's workshop a great success, and I open the workshop and I hand over the floor to Dr. Neeti Tiwari to carry on the day's proceedings. Over to Dr. Neeti for the proceedings.
Unmute. Yeah.
Good afternoon. Can you hear me?
Yes, madam.
Good afternoon, everyone. So without wasting any further time, we move on to the session 1, for which we have esteemed chairpersons, Dr. Sonia Malik, who is the director and head of the department Southern Fertility and IVF, and she has been the past president of Indian Fertility Society. Dr. Mala Srivastav, who is a senior consultant and professor in Gripmar in Gangsar Gangaram Hospital, New Delhi. Dr. Kavita Agarwal, who is assistant professor, Safdarjung Hospital, and she is also the chair of the AOGD Infertility Subcommittee. And Dr. Professor Surveen Guman Sidhu, who is director and head of IVF and Reproductive Medicine Center. Now I hand over the program to the chairpersons to invite the speakers. Dr. Sonia.
Thank you very much, Neeti. Good afternoon to everybody. First of all, let me extend having me here today for this esteemed and very pertinent, very topical subject of IUI in the time of IVF, and it actually needs no introduction. Hello? Can you hear me? Can everybody hear?
Yeah, your voice is cracking, ma'am.
Can you hear me now?
Yeah, very clear.
Better.
Okay. Yeah. Okay. Just a small introduction of Abha, whom I know. I think everybody in this circle knows. All those who are attending this workshop would definitely be knowing Abha Majumdar. She's a name to reckon with in the field of IVF and infertility, and we all know her as the director and center head of IVF Center at Gangaram Hospital. So over to Abha to let us know what it is about IUI.
You need to unmute yourself.
Yeah, I'm doing that.
Yeah, we can hear you.
All right. Can you hear me? Can you
Yes,
hear
ma'am.
me?
We
Yes.
can hear you.
Very clearly.
I can hear you.
So I'm very glad that we picked up this topic, which is so close to my heart. In the era of IVF, I still feel IUI is the first line treatment for so many patients who unnecessarily are pushed into IVF. Now, I would start with the world history of IUI, which dates back to almost 350 years. The first description of spermatozoa was 350 years ago by Anthony von Leeuwenhoek, after which, 100 years later, first birth of three puppies in a canine happened by IUI, following which John Hunter in 1770, that is about a little later, say 250 years later, reported the first case of human intravaginal insemination because of severe hypospadias. And in the same time, Marion Sims also reported 55 intravaginal inseminations, creating only one pregnancy. And it was very obvious because he believed that ovulation occurred during menstruation. But then soon after, there was a start of new era in ERT with intrauterine insemination. They moved from intravaginal to intrauterine. And the first report on human IUI appeared in 1943, which is almost 80 years ago, 75 to 80 years ago, which was a new era in assisted reproduction. And then frozen donor sperms by preserving sperms for the first time using glycerol was reported 10 years later. It was published even 10 years later because of the antagonism he received from society regarding doing a donor insemination. But the real dawn of IUI happened with the introduction of IVF, which is regarded the most important milestone in the history of IUI, as it renewed interest in sperm washing procedures, which was the key to develop IUI. Soon after, the first European collaborative report on IUI appeared of 127 births from 20 clinics across Europe. And then after that, IUI became evidence-based method, which described IUI for cervical hostility, unexplained infertility, and mild male factor infertility. In 2005, which is just about 15 years ago, IUI found its place. So if we look at IUI, then it was conceived in 1943. The intrauterine life for IUI to take birth was almost from 43 to 2004 or 5. So it had a very long intrauterine life, where it had to first, we had to determine the timing of ovulation, then we had to develop the sperm preparation and freezing techniques, and then we had to compete with evidence to establish this as a procedure and give birth to IUI. So evolution of IUI in humans happened with partner semen, originally for couples with had a dysfunction of the male organ. Then they went up to donor insemination. This was for esospermic men or very low sperm counts, or where they thought there was an inherited genetic disease linked to Y chromosome. And then is the era today, where the partner semen or homologous insemination is presently mainly for unexplained and mild male factor infertility. So what is intrauterine insemination? We need to understand intravaginal is a very different story when we started our journey with. IUI is a relatively simple, low-tech, safe, and inexpensive treatment modality compared to IVF-ET. And the rationale behind IUI is to increase gamete density, the female and male both density at the site of fertilization, even when sperm or cervical mucus abnormalities are present. And who benefits most? Like it is obvious, mild male factor, first line management for couples with unexplained infertility, where we don't know whether it is the man or the woman responsible for infertility, and couples requiring donor insemination. Having said that, IUI moved forward from 2005. The first Cochrane systematic review was published in 2012. And what did it say? It said IUI versus timed intercourse. If we stimulate a cycle in both type of patients, we would have an increased chance of pregnancy when we combine stimulation of cycle with IUI. Similarly, vice versa. Ovarian stimulation plus a natural ovulatory cycle. And both, if we combine IUI, again in an ovarian stimulation with IUI, there was a significant increase in live birth rate. So having said that, soon after this, the roller coaster ride for IUI started in the world. What was this roller coaster ride and how did it go on this? Well, it came up with the NICE guidelines in 2013 when the UK National Institute for Health and Care Excellence recommended that intrauterine insemination with or without ovarian stimulation should not be routinely offered to couples with unexplained infertility, and that IVF could be considered after 2 years of expectant management. However, 2 years later, a survey was done of all UK fertility clinics, and they reported 96% of physicians still continued to offer IUI. But then, what is the problem with UK? UK clinical commissioning groups, that is CCG group, CCGs, and some international funding agencies use NICE guidelines to construct and justify funding policies. All funding of IUI in several London clinical commissioning group clinics was immediately stopped. So nobody got any funding for IUI. The preference for the more expensive and intrusive IVF treatment option over IUI raised concern to such an extent all over the world that NICE were pressured to hold an update review. NICE agreed and identified the need to review IUI practices in June 2015. But then what did they do? The verdict by NICE after reviewing was for couples with unexplained infertility, mild endometriosis, and mild oats who are having regular unprotected sexual intercourse do not routinely offer IUI. So they did not go back on their work with or without ovarian stimulation and advise them to try conceive for a total of 2 years before IVF will be considered and will be funded for them. However, there was a lot of furor all over the world. But where did they allow IUI, the NICE guidelines? They said you can only have IUI if the couple is such that they are unable to have vaginal intercourse, or there is a specific consideration like a HIV positive man and a HIV negative woman, and you need sperm washing, or people in same sex relationships. But then NICE update guidance on IUI was rejected by professionals. And here I would show you a editorial from Professor Roy Homburg and Dr. Ghulam Bahadur, who's going to be our next speaker. What happened? In Human Reproduction, an article appeared saying first-line fertility treatment strategies regarding IUI and IVF require clinical evidence. And this said national funding strategy should include IUI for most first-line treatment options, and the UK NICE guidelines need a radical review of IUI procedures. So having said that, there was strong advice to dismiss the NICE guideline update based on significant professional representations highlighting the lack of evidence against IUI practice. We strongly advise clinics to dismiss the NICE guideline uptake. Having said that, there was ESHRI in Geneva in July 2017, and a very beautiful paper from Auckland was presented by Cindy Farquhar, who's the director of her center, where she showed results of a randomized control trial with very strong evidence that 201 couples with 3 to 4 years of unexplained infertility were randomized to receive 3 cycles of IUI or expectant management. The live birth rate in IUI cycles was 3 times higher than expectant management. At the same time, the course organizer for the ESHRI meeting was Professor William Omblet, and his verdict was if the tubes are open, there is no reason not to do IUI. And the turning point editorial was published by him which turned the tables in favor of IUI. He is the editor of Facts, Views, and Vision OB-GYN, and in 2017, his editorial read the title of The Revival of Intrauterine Insemination, Evidence-Based Data Having Changed the Picture. And he said that according to a number of high-quality studies, IUI with homologous semen should be the first choice treatment in case of unexplained and moderate male factor infertility. IVF and ICSI are clearly overused in this selected group of infantile couples. The limited value of IUI in infertility treatment, as mentioned in the 2013 NICE guidelines, was surely a premature statement and should be adapted to the actual literature. Then there appeared in the same ESHRI conference another very interesting paper by N.A. Denhoff from Netherlands, and later on it came in as an open access article in the BMJ. The super study, it was protocol for randomized control trial comparing gonadotropins and clomiphene citrate for ovarian stimulation in IUI, and he found that even clomiphene gave a high pregnancy rate of 26% versus 31% by gonadotropin. And therefore, clomiphene also has a place in these IUI cycles according to this trial. However, there are still controversies in this. Then came in the global review, the global recommendation in 2018 in the journal, which has the highest impact value, human reproduction update. And here we had Professor William Omblet also, who included his views in this. This is a 20-page document, and these are this is the summary of the draft recommendation and strength of evidence. I will not take you through the whole slide. I'm just highlighting one column. When is ovarian stimulation required in a IUI cycle? In couples with unexplained infertility and men with a total motile sperm count above 10 million, IUI should be combined with ovarian stimulation to improve live birth rate. So now ovarian stimulation is to be combined in all cases. Then I take you across another slide, the same draft recommendations continuing, and again draw your attention to number 10 recommendation, which says what is the cost effectiveness of IUI versus IVF ICSI, because this was the main point on which NICE made their guidelines and rejected IUI as a treatment option. But then, and this is a very high, this is a very high recommendation in couples with unexplained infertility and men with a total motile sperm count of more than 10 million, and those who have a prognosis of pregnancy without assistance of less than 30% within a year, at least 3 cycles of IUI with ovarian stimulation is the most effective option. Having said that, I bring you to the last part of the recommendations of the draft, which is the summary of the whole draft. And when I say here, in this review, ovarian stimulation only refers to ovarian stimulation with gonadotropins unless stated otherwise. Well, they still feel that clomiphene citrate or tamoxifen are acceptable alternatives to low-dose gonadotropin for low multiple pregnancy and birth rates with lesser cost, although at a lower live birth rate than with gonadotropins. In addition, a good practice point, I want to draw all your attention to this. This is so good. An alternative to cycle cancellation if you make more follicles is aspiration of excess follicles at the time of HCG injection or LH surge might be an additional option for reducing the risk of multiple pregnancy in IUI with ovarian stimulation. And another point is addition of GnRH agonist to gonadotropin in IUI ovarian stimulation is not recommended because there is no increase in pregnancy rate despite increased multiple pregnancy rates and increased cost. And here I will bring up my own study where we used antagonist, gonadotropin releasing hormone antagonist in IUI cycles with gonadotropin, and we found addition of GnRH antagonist to gonadotropin stimulated IUI cycles results in no significant difference in clinical pregnancy rate. So having said that, I went into literature, and 2020 I found another article which supports oral ovarian stimulation agents for unexplained infertility, and they feel that the randomized data do not support the use of gonadotropin for ovarian stimulation IUI over oral ovulation stimulation agents in women with unexplained infertility. Both have an equal role to play. But then the controversies continue, and the roller coaster ride for IUI is still on. And now it is oral ovarian stimulation versus gonadotropin. So we'll have to clear out this also in times to come. Therefore, to conclude, I would say factors associated with a poor outcome in IUI. You see, we need to select our cases very well for IUI, and that is when we get success. Apart from tubes being open and a sperm count being over 10 million, we need duration of infertility should not be more than 4 years. IUI works better in these people. Poor sperm quality. If the motile sperm count is less than 10 million, again, IUI has a poor prognosis. Female over 40 years of age, untreated endometriosis, generally it is mild or minimal endometriosis, or maybe a little bit of endometriotic cyst, which takes it to stage 3, and distal unilateral tubal fracture or block. And therefore, my take-home message for the audience is all of us, IUI with ovarian stimulation is recommended as the most cost-effective strategy for mild male factor infertility or unexplained infertility who have a poor prognosis of becoming pregnant with just normal coitus. There is no strong evidence in support of offering IVF as a first-line strategy in couples with unexplained and mild subfertility. So this has been the revival of IUI, though it has gone through a roller coaster ride after its birth in 2004. But then newer developments must continue, but old can still be gold. So don't let us not give up IUI as a method of conception. Thank you very much.
Thank you very much, Abha, for taking us through this journey of IUI and helping us to learn about its revival. It is important for us to understand why IUI is important for this country, because we are a poor resource country, and therefore we should not be rushing all our patients into IVF, one. And second, it is heartening to know that even the oral drugs are working as well as the gonadotropins in whatever preliminary data you have presented. Of course, time will tell, but yes, we should not just ignore the oral agents because they seem to be doing well. And again, because we are a poor resource country, we should first of all try them before we go on to more expensive forms of treatment. Thank you very much, Abha, and I think we can move on to the next one.
Thanks, madam. Our next speaker of the day is Dr. Ghulam Bahadur. Sir is going to speak on the art and science of ovarian stimulation for IUI. Sir is currently a consultant clinical andrologist at both Homerton University Hospital, London, and in North Middlesex University Hospital. Sir has main involvement in andrology. He's very focused on improving IUI success rates and has written and lectured extensively on this subject. He has been the major contributor in the field of immunology and virology cells, and he has published the first case of human ovarian tissue cryopreservation. Recently, he has published work on maternal fetal transmission of SARS-CoV-2. Over to you, sir, for your deliberation.
Well, dear colleagues, it's an enormous pleasure and privilege to be invited here to join you, especially from being part of my parental country, India, and to also see many of the fine colleagues that I have been meeting at meetings, but now we are equally good at meeting virtually. Now, must congratulate the organizers for really constructing such a fine program and to be revisiting IUI in the era of IVF, where it should be the other way around, I think. And if the title of my talk is The Art and Science of Ovarian Stimulation for IUI, I would ask you what intellectual bits that do you really need to see in this part to try and translate into your clinic. And so I thought the other alternative is how to improve your IUI success rates while minimizing risks. Now I have, as Dr. Abha has really presented so well, laid the groundwork, and I have published quite extensively now. And in fact, if there was any fighter for the NICE guidelines, it's been me. And right at the bottom, you will see that I've written in the BMG about the pitfalls of the NICE guidelines. Hello? Can you hear me?
Yes, very clearly.
About the NICE guidelines, and really the question that they asked there was using the real question that they were asking was, using very low dose clomiphene citrate, was that any different from expected management? And the answer is you don't need rocket science to conclude that there would be no difference there. And this was done by a small group of people which I felt had interest in IVF. when it is me who forced the NICE guidelines to review this, but I wanted them to ask the bigger question: was IUI really better than IVF? But they asked the same question again, and it's not. Next year, they will now, I think early next year, they will ask the same question. I hope not the same question, but they will review IUI again, because there's a lot of new data that's coming through. And one of the biggest paper in the field we published just recently, and I urge all of you just to open the British Medical Journal open. It's a free access, looking at the difference between IVF and IUI. In that, we said that 2.35 IUI cycles are needed to match one IVF cycle using the mean success rates in the UK. But if you're at our clinic at the North Middlesex Hospital, where the success rates were much better, then you can lower that to 1.7 to 1. And this is actually no different when you consider a mid-IVF to an upper IVF unit. You have literally one IVF matching two IVF cycles. That's a kind of difference that we'll see. So this is not very different from the IUI cycles. Further on, if you think how many IVF cycles are needed to theoretically achieve one pregnancy, it is 3.7 IVF cycles or 8.7 IUI cycles. Or if you improve the success rates, you can actually begin lowering the number of IUI cycles to receive to match the to achieve one pregnancy. And we did a quick calculation that if you have an upper IUI performing clinic to mid-performing IVF to upper IVF, you're actually spending a lot more money to achieve one live birth. And in fact, if anything, the risks were increasing. And in fact, looking at it the other way around, you were actually budgeting for a 70% failure rate in IVF. And this is something a lot of people are not aware of. Within this paper, we did the calculations of the maternal neonatal costs, which remain hidden so far, and it is a huge cost burden to the UK NHS. We also did the cost-effective study within this paper, showing that if you use the mean success rates of IUI and IVF, it was actually £42,000 cheaper to get an IVF IUI birth compared to IVF. And if you came to North Middlesex, you would achieve, it was actually even more cost effective at £76,000 per live birth. And we also, within this paper, show that IVF needs to work very, very hard compared to IUI to match the same level of success. And I think you can look at this paper very carefully, and you will see that at our North Middlesex Hospital, where we average 15.6% live birth rate per cycle, IVF would actually need to match 42% live birth, and there are not many IVF clinics in the UK that actually do that. In terms of improving IUI success rates, you need to know the patient pathology, the age of the woman, the male factor. I've introduced the concept of consecutive ejaculate. We need to dwell into the stimulation protocol, the different drugs and its effect, and what the status of the endometrium is, the timing of trigger with different drugs, the timing of insemination, and then multiple inseminations, minimizing risk and the cost effectiveness. And the evidence so far shows that IUI is definitely significantly better in terms of fertility treatment. Endometrial scratching has also got a good relative risk. I mean, these are just general factors which may contribute to success rates. And the other success rate is that if you were to increase your follicle numbers, then you have a much better chance of achieving your pregnancy, as you would if you increase your total motile sperm count above 5 million. But the downside is that if you were to increase your follicle numbers to beyond 3 and beyond, then you can expect to see your multiple births increasing, and that is not what we want in IUI. Coming to the theme of the talk, I think this is a picture that you would show your patients during your consultation, and here's your clomiphene, here's your letrozole, and here's your HMG. And one thing that did strike me with clomiphene was there was a chlorine group attached directly to a carbon with a double bond, and instantly that told me that there was some potential toxicity there, which seem to have missed people's eyes. So the kind of drugs that you are administering is the oral agents, clomiphene, tamoxifen, and aromatase inhibitors, and your injectables are gonadotrophins and your recombinants here. And in terms of gonadotrophin, the one that we have been using at North Middlesex has been this one here, Menopur. In terms of clomiphene citrate, it binds to the estrogen receptor and acts competitively, and it's indicated in anovulatory infertility. So basically, it's just estrogen receptors are being blocked, and there's an estrogen negative feedback is inhibited, and the hypothalamus thinks that there's an estrogen deficiency, and more FSH and LH is secreted in response to the GnRH. And so moving on to letrozole, is that letrozole does not deplete the estrogen receptor in the target tissue, and so there's no persistent anti-estrogenic effect. And it has a much shorter half-life compared to clomiphene citrate, which is about 5 to 7 days, which we need to consider. So in terms of clomiphene citrate, so in terms of the aromatase inhibitors, they block the conversion of testosterone and androstenedione to estradiol and estrone respectively, and they seem to be free of effect on the endometrial and the cervical mucus here. In terms of gonadotrophin, you're just pushing more FSH, LH with a view of producing more follicles here. So in terms of stimulation, the kind of things that my colleagues are thinking is, what dose do we give? Shall we give it daily, or shall we give it in alternate days? If we start at a lower dose, shall we step up? Or shall we start at a higher dose and then step down? What about combining them together, like HMG and clomiphene, or HMG and letrozole? And if so, is there any merit if we started off with a cheaper drug first to contain the cost of the drugs, and at some stage you might think in terms of abandoning the cycle here. So I've laid on some of the kind of thinking that we have had of using HMG, and also not only at our clinic, but I've also been advising another clinic in London who were in a similar predicament of having low IUI success rates. And so when we began, we were actually suffering with very low success rates here. And that was purely because we're using clomiphene citrate here. And we decided to go on to 75. Ultimately, when we looked at all the data, we abandoned clomiphene and went on to HMG at 75 units, and still the success rates were not so high. And then we went to 150, and although that data is up to 2014, up to 2020, we're actually achieving 20% per cycle success rate, or near enough. But if we were to think in terms of how many women, what percentage of women who get pregnant, now for the past 5 years, we have consistently been around 33% of the cohort that walk into our doors will get pregnant, and most of them will achieve a live birth, which actually is very, very good, and it actually beats some IVF clinics in London, I can tell you that. So in terms of evidence, we see that a natural cycle IUI perhaps is really not as good as clomiphene citrate, but HMG is a lot better, to be honest. So, and in one of the other papers by Diamond and Legro, they do show that the gonadotrophin is much better than clomiphene, is much better than letrozole, although another paper shows that letrozole group is a lot better than the clomiphene citrate group here. So in terms of multifollicular environment, we could achieve, this is a paper from France, they achieve 9.4% per cycle with 2 mature follicles. They could actually increase it to 15.2% per cycle. And these are the kind of things that we would actually be seeing within our clinics. In fact, if you go from 1 follicle to 2 follicles, you actually theoretically 3.44 increase your chance of a pregnancy. But then if you look at, if you do combination treatment with clomiphene HMG and letrozole HMG, it seems that the letrozole HMG really is a cut above the clomiphene and HMG combination here. Factors that you will need to take into account is sperm motility and DNA fragmentation, and both of them are of significant contributors to the ability to achieve a pregnancy, that where the odds ratio is 4.8 and 24. But when I introduced the concept of consecutive ejaculate, you know, the DNA fragmentation is far lower in the consecutive ejaculate, and I will show you some data later on. And although this is some data on that the shorter abstinence had lesser DNA fragmentation, but I'd like to keep that into perspective here. This was from our own data where we showed that a sample produced within 10 minutes to half an hour of the first, the rapid motility was much better. That's on the right-hand side compared to the first sample. And we did publish in the Journal of Obs and Gynae of India, where we had to use consecutive ejaculate, it's because we did not have enough sperm. Now you think about giving women that those women are not getting pregnant because they don't have enough sperm. If you had a mechanism by which you could give them more sperm, the likelihood is that they would get pregnant much easier. And so why not try consecutive ejaculate? You just add more sperm, and they are the easiest group of women to get a pregnancy. And this is just another data where CASA data, which shows how the short abstinence time gives much better linear progression than the first sample here. And here's data on the DNA fragmentation that the for less than 2 days to 5 days and over is that the DNA fragmentation is much less. On the question of single or double IUI, we published this between Roy Homburg and myself. We reappraised it and we showed that it is significant to do a double. The success rate will be significant if you were to do a double IUI. And that was from the Cochrane review. So the original Cochrane review always said that it was significantly better. So I don't know why it was later on dismissed as not working. And the kind of results that you would see to the left is that it is so much better, the success rates compared to a single IUI. And in fact, there was a 2-fold increase in pregnancy following double IUI, and especially and it seems to work better with gonadotrophin stimulated cycles, and also where there's a male factor issue. here, that it seems to work a lot better. And so that resolves the question in a way about the enigma of timing, because we are so as to what is the best time to do it. Now, if you were to do the consecutive, the double in IUI, then that in a way helps reduce that the dilemma of what have we got the timing right. Now, I also have to say that the trigger time has been something for the Clomid cycle over the years have been misjudged. They have been triggering at a much lower size, when actually the optimal size for trigger for the Clomid cycle has been 20.4 millimeter. And in this sense, I think that perhaps we have not done the clomiphene cycles justice, because over the many decades of the use of clomiphene, maybe the trigger times and just the whole management and the thinking has not been so defined and refined. And in terms of motile sperm numbers, it seems that there's no benefit beyond 20 million sperm. But although this paper is showing that, but I also felt that the success rates were very poor. But from our own work, we find that inseminating over 20 million total motile progressive sperm is not detrimental to achieving a pregnancy. Now, the issue about endometrial scratching I brought in is because it technically facilitates endometrial decidulization. The injury leads to healing with activation of the immune response with cytokines and a whole clutch of other factors. And it's and that a slow endometrial maturation improves the synchrony. So you could actually technically apply this to IUI. And this has been done, and it's shown that if you were to do the endometrial scan in the follicular phase, as opposed to a period before, it is actually associated with a higher success rate, and the odds ratio being 2.5 or thereabout. So the question about double insemination that I have raised, you can choose the time between 34 hours as one IUI, and double between 18 to 24, and the other 36 to 48 hours. But I think this is an open area to think about, is that you actually have a much significantly better success rate here. And in terms of the influence overall, is that the multiple logistic regression models show that if you adjust for age, BMI, serum estradiol, and follicle size, follicle numbers, is that the association between the endometrial thickness and the pregnancy remains significant. And we have to think in terms of the endometrium is being truly underestimated in the infertility treatment. And here, if you look at the endometrium with different drugs, in fact, it's not a very clear slide, but you can look that up in, is that with the letrozole, it seems to taper off. But the bottom line is that the optimal success rates that you're going to achieve your pregnancy is 10 to 14 millimeter for IUI conception. And another paper that grabbed my eye was that low-dose aspirin in the course of your stimulation, which a colleague of mine in London has just applied everything that I told her after battling away with me, and suddenly they're getting amazing success rates. I don't know the logic of it, but I think there is publication to show this here. People often ask, is luteal support really needed? It seems perhaps for clomiphene citrate cycles, there seems to be no benefit, but in the gonadotrophin cycle, there seems to be benefit here. And in terms of what about the success rates in unilateral tubal blockage, is that it is almost half of that if there were 2 tubes, and that the proximal is perhaps better in terms of success rather than the distal. The distal is the proximal tubal blockage and the distal one. There are differences which you need to unravel here. So this is data from the clinic that I was helping, because they had a similarly poor success rate, and they just went from one end to the other. They went 150 units of gonadotrophin alternate days. By the way, it's not every day, because we do that. And when I asked our nurse, and she said it seems to get a better kick in the initial, and then you still have the scope to step down. And that's been quite interesting for me. But this other clinic added 50 milligram clomiphene citrate. And so what happened in that cohort of patients is that a third of them had only one follicle. Nearly 45% had 2 follicles. They only had 2 sets of twins in it, with a pregnancy rate of 18% per cycle in both. And 22% had 3 follicles. And the pregnancy rate, there was 26% per cycle. No multiple births, surprise, surprise, but I wouldn't rest my laurels on that one. And in that very specific group of over 35, and they went balmy, they went 150 to 225 HMG plus 50, and their pregnancy rate was 27% per cycle. Of course, we need, you must always be very, very careful to make sure that you abandon cycles. If anyone with 3 follicles, you definitely have to review it on a case-by-case basis. So I'd conclude generally is that you do need there's no point in having high success rates if you don't take account of the risks. You do need to control the OHSs and multiple births. Bifollicular environment is highly desirable. It seems to me that gonadotrophin stimulation is the way to go, and that gonadotrophin and letrozole seems to be something that is really catching on in a positive way. There have been question marks about clomiphene. I mean, we abandoned clomiphene very early on because we were frustrated with it, because we were simply not getting the success rate. And I think that when I saw the chlorine next to the carbon, I instantly thought it must cause irreversible damage to the endometrium long term, although it is difficult to, I have not found any studies that actually confirm that. I introduced the concept, the double IUI, although we haven't practiced it, is one way forward, and that the consecutive ejaculate is something quite amazing. And I think you have to try that if you haven't not already doing this. Endometrial scratch is something we haven't been doing, but there seems to be some data to suggest that we haven't been adding aspirin in our cohort, but I know another group has, and they seem to be doing amazingly well. I've commented on bed rest at some stage, and my paper is actually showing that IUI can easily match IVF. It certainly beats the cost effectiveness by miles. And this is, I've been told by Roy Holmberg that paper will fare very significantly. So, dear colleagues, I say to you, work on improving your IUI success rates. You won't believe it. It is IUI that is the future for the patients. And thank you very much for your attention.
Thank you, sir. Your deliberation has been really very informative, and you have nicely summarized that IUI is here to stay in well-selected cases.
Thank you.
I would now like to introduce the next speaker. We all know him for his research. His research work is tremendous, Dr. Mohan Kamath. Professor of Reproductive Medicine, CMC Vellore, a member of the editorial board for Cochrane Fertility and Gynecology. Over to you, Dr. Paul.
Yeah, thank you. Thank you all. I'm just loading my slide. Yeah. I'd like to thank Dr. Abha, Dr. Shweta, and the whole team of AOGD for having me over here. I'm audible, like
Yes.
Yeah, thank you. So there'll be a little bit of overlap, and that should be okay because we can discuss the same points, and probably the audience can also have some more discussion on some of the points which I'm kind of not totally in agreement with Dr. Bahadur, but then we can always discuss that at the end. So I don't have any conflict of interest. Of course, I'm on the board, but I won't be quoting any of those, any of the Cochranes which I have, authored. So let's get back to what exactly is the evidence and how do we apply this evidence for IUI in our day-to-day practice. So what I thought is I'll cover a few things, which is about indication, single versus double. Dr. Ghulam Bahadur has covered that, but we'll again look at it. Then of course the timing, the number of IUI and tag, and probably I'll share some of our experiences and our own data, and how we can actually look at practical issues that can be tweaked in our day-to-day practice. So I'm skipping the ovarian stimulation part because Dr. Bahadur has done it very well. So that was something that was to be covered in the previous talk. So I'll skip that and straight away go to the other aspects of IUI and how we can make this practice of IUI in our centers better and improve the success rate. So let's look at the data again. And we all know that the success rate for IUI is between anywhere from 8 to 22%, quoted in various studies and so on. It remains an important treatment option for most of our patients for various indications. Now, any clinic which is clocking around 10 to 15% per cycle for a homologous IUI, I think is doing fairly well. If you reach towards 15, it's great. Up to 10, it's fine, but that's what it will be. But let's see how we reach there. So a quick update on what are the indications. So as rightly said, and it's been pointed out earlier as well, the primary indication for IUI remains unexplained infertility, mild male factor, minimal mild endometriosis. Sexual dysfunction, if there's an intercourse issues, you can. Cervical factor is something that we don't encounter often in today's practice, but that's also mentioned for completion. What I want to clarify here is PCOS and anovulation is not an indication for IUI. This is very commonly seen in practice, but this is not something that is backed up by evidence. None of the recommendations point towards a treatment option for PCOS, but I see this very often, so I thought I'll clarify on this particular point that PCOS is not an indication for IUI unless it's a combined factor like a male factor and so on. Now, what people need to understand, and we need to dig in deeper, is you need to see where is your unit situated and what is the population that is coming to you. That is because there are various factors and confounders which affect the IUI. But the two main ones are the female age and duration of infertility. These are the two main factors. So when you're looking at studies, look at these factors like what's the mean age of the population, what's the duration of infertility, what kind of stimulation protocols they have used. Gonadotropin usage consistently gives better results. That is something that's been shown. Whether they were looking at single versus double, whether they were talking about a single IUI or a cumulative effect, because these are very important pointers towards what's the quoted rate. So if you are not looking at this, it's not a good idea to extrapolate whatever is there in the studies to your clinic. See, if your clinic is a secondary level, you get patients who are fairly treatment naive, then you're likely successful. Let's say I'm sitting in a tertiary center, my group of patients are those who have lower prognosis with IUI, somebody who's at 8 years, 10 years of infertility, so on. So I don't expect to clock more than 10, 12% per cycle. So this difference is very important when you are looking at your practice. Don't go carried away by what has been achieved by another unit. So let's look at some of the important points, practical issues. Yes, this has been spoken again. I will speak timing of IUI. So if you're planning a trigger, So what should be your IUI? When should you plan IUI? So typically somebody says 30 hours, 36 hours, 38 hours. So there is some evidence which looked at 32, 34 versus 38, 40. You can see the pregnancy rates where there are no significant difference. This is a Cochrane review which actually looked at synchronizing IUI. This is a very big, good review way back in 2014, slightly outdated, but still quite relevant. So basically they have looked at various subgroups of 24 versus 36, 24 versus 48, and 34 versus 48. And what you can consistently see is the longer interval helped in getting pregnancy, but nothing was significant. But then the general consensus was that if you are clocking between 34, 36 hours, it's better, but 24 is not bad. But the trend is definitely towards longer interval. So because many of us believe that a 24 hours IUI is also acceptable, but that would be a shade earlier. Practice point from whatever the evidence presented is, what I understand is there's a fair bit of flexibility for us when we plan an IUI. So if you have a busy clinic and you have to run around doing a surgery and so on and so forth, unlike IVF where you have to strictly go in and do a pickup at 35 hours, IUI gives you that flexibility of 34, 38 hours and nothing is going to go really wrong in terms of affecting the outcome. At our institution, typically between 36 to 38 hours is when the IUI is done post HCG. Now the other issue is when to give trigger. So I'm not differentiated between a CC stimulated and a gonadotropin stimulated, but this particular trial actually managed to do a randomized trial on a size which is between 16, 17 versus 18 and 19, and they gave the trigger. And the key was they didn't find any difference. Now, this is a difficult RCT to pull off because there are going to be a lot of intra and inter-observer variation, but whatever said and done, they have got a trial which is published, and it's the evidence that we have. So what I would suggest is this again gives us the flexibility. That means that if, like, I have a lot of students learning, so if there is an error in judgment or marginal error in calculating, let's say it was 17 and somebody actually wrote off as 18, it need not really matter. But I would take the point of what Dr. Bahadur did mention, that the CC IUIs probably you trigger a little later. But typically, I hardly use CC in our practice. We mostly use a CC gonadotropin combination, and anything beyond 17 mm is fine. Okay, so that's when you would probably plan a trigger. Now, the question of double IUI, as I could make out from the previous talk, is Sir has done a lot of work on it, so probably we can again look at it. But whatever evidence that I gathered, one of the issues that needs to be looked in deeper is that where is double IUI being advocated? So the Cochrane actually mixed both the unexplained and mild male factor, whereas these two need to be looked at separately. So this particular systematic review, which looked at double IUI in unexplained infertility, polizos, they figured out that they did not find any clear advantage of double IUI in unexplained infertility when you pulled in 6 randomized trials. Now, I would agree that the systematic review did show the next one, which was published in Asian Journal of Andrology, that the pooled results are favoring double IUI in male factor. Now, what needs to be done here is there is an exercise called sensitivity analysis. We can make out here that one of the trials, that is Liu 2006, contributed quite a bit, 48% weight. And if you take out this particular trial, the whole effect is gone. And this was held against the whole review pool analysis. And what they felt was, even the Cochrane review, this particular trial had a lot of impact on the overall estimate. So when you take out this study, there's no longer significance in terms of male factor and double IUI. So overall, I think Dr. Abha Madam did show the ESHRE guideline on IUI, and that also does not recommend double IUI as on today. So in practice, I would be cautious. I would not push it for a double IUI at this point of time. This article actually went into the cost factor and so on, but I would take it from the patient point of view. It's a huge psychological burden. The guy has to come twice in 2 days and give a sample. It's something that adds to psychological burden as well as the cost, and it straight away increases your lab work to double. So if you're handling 500 IUIs, it will become 1,000. The number needed to treat calculated by this particular group was 81. That means that 81 couples needed to undergo double IUI to get one extra pregnancy. So it's up to you to decide whether you want to do that extra 80 couples for one extra pregnancy in your unit. Moving on, yes, urinary versus recombinant. So if you have dilemma whether you need to give that urinary or you feel it's slightly inferior, let me give a recombinant. The data does not suggest that. The pooled trial of two randomized trials did not show any particular advantage of a urinary or a recombinant trigger. So you are okay with both. Practice point is not to worry on these issues. Now, another fad which came in probably a decade back when ANTAG started getting used in IVF, everybody thought, let's start using it in IUI, especially if you're looking at an aggressive stimulation with gonadotrophins, because your premature LH surge, which roughly counts for something like 20% in a gonadotrophin stimulated IUI. If you take off that 20%, because ANTAG is very effective in preventing premature LH surge, you would expect an increase in pregnancy rates. So don't get worried about the pregnancy rates. They look pretty high, but they are actually cumulative pregnancy rates of 3 to 4 cycles. Okay, and they found that the ANTAG usage had led to a dramatic increase in the IUI cycle. But however, these results were not replicated. Remember that science, we need to replicate results. So subsequently, as new trials came out, this was a multi-center, double-blinded randomized trial with the population shown unexplained mild and endometriosis. The live birth rate did not change. This is one cycle, 8 versus 10. So effectively, they concluded that it's not beneficial to add ANTAG in a stimulated IUI cycle. Again, the evidence is little conflicting. You can look at the trials here in this particular systematic review, and you can see that the OR is actually favoring ANTAG. Okay, so we have one trial sitting there which didn't show any effect, but overall, there was some benefit of adding ANTAG. They did something called subgroup analysis, and what you can figure out is wherever PCOS population was there, the ANTAG did badly. Whereas non-PCOS population, ANTAG did slightly better, and there was some advantage in terms of clinical pregnancy rate. However, people are not convinced, and even now, the recommendations are not in favor of ANTAG. I would not put that. Cost considerations are important in our country, and there's no real big advantage of adding ANTAG. Yes, you can probably use it in cases where you want to schedule, you have a weekend issue, or you have a case where previously there's been a premature rupture, like somebody has got a rupture within day 7 or day 8 and you want to push it a bit. Those kind of cases, you can probably think about ANTAG, but otherwise my take home message here is to avoid ANTAG in IUI cycle. Moving on, do you want to have a natural surge or you want to have a trigger induced surge in IUI cycle? So this particular Cochrane again had 4 trials which compared an LH surge with trigger. And remember that out of these 4 trials, if I remember correctly, 3 of them were CC stimulated. So the idea was to not to make the patient come to the hospital for IUI, in terms of or injections or just for monitoring. They just went on, took the CC, had these LH kits with them, and they wanted to plan the IUI based on home-based treatment. Like you can just call up and tell I had a surge and they'll come for the next day for the IUI. So in this, they did not find any difference in pregnancy rates when most of the trials were CC. However, we ourselves had a trial which was almost 400 patients published a couple of years back, where we looked at gonadotrophin-induced cycles. And we found that urinary LH versus ultrasound monitoring followed by a trigger, HCG, did not result in a higher pregnancy rate per cycle. So in fact, in our thing, urinary kit 10% false negative was there. We compared it with serum LH. So we had some data on that. So other issues, of course, age factor. There's no particular cutoff. So I would say you have to look at the context. Like if somebody is married late, it's 36, 37, and it's 1 year infertility and unexplained, then you can probably look at an IUI. But remember that age, especially beyond 35, has an impact on the most effective treatment, ART. So you have to accordingly see. Above 40, the data is quite low in terms of the success rate is quite low. It's something like 1 to 5%. I don't know, even the IVF might reach the same level beyond 40. Now the question comes, how many times do you want to offer IUI? Now generally up to 6 is recommended, but most of the studies have shown that after 3 to 4 cycles of IUI, stimulated IUI, you kind of, the pregnancy rates go down. So the landmark study was from this Human Reproduction 1999, where they found initially the success was something like 18 to 15. And as they went beyond 3 cycles, the success rates dropped dramatically. So they recommended up to maximum 3 to 4 cycles. So the HRA recommendation also stand at 4. I would say like somebody has received already 3 to 4 cycles in some other unit and then you restart again is not a good idea, because the success rate definitely starts going down beyond 4, but there is no upper cutoff, okay, because we don't have data for that. There is some concerns every time in one of most of the conferences. I do find this, that people tend to ask me, should we do ultrasound to check if ovulation and try to time the IUI accordingly. Now this is something that I cannot find any studies at all looking at this particular question. There is only one study which came close to this, is this particular retrospective study which looked at uterine contractions and ovulation after IUI. That is, they had done double IUI and they just looked at how were the uterine contractions after the IUI and the ovulation status. So only thing they did find was documentation of ovulation was associated with higher pregnancy rates. However, it does not mean that we start doing this. There's scarce evidence, as I said. This is something widely practiced in this part of the world, but I won't really advocate that. Please remember that your patient needs to come again and again. We sometimes don't factor this in, but indirect cost goes up. Every time she has to come, the husband has to come, wife has to come. This is indirect cost which goes up. Workload increases. You go on doing this the ultrasounds. The stress for everybody goes up. There is nothing to suggest that timing an IUI after ovulation will improve your pregnancy rates. So if you have data, we need to look at that. Again, should we make it more complicated? Doing an ultrasound guided IUI, there's one trial there which showed no improvement. So that means that in IUI, it's a lot more forgiving rather than when we compare it with embryo transfers. So, you can do IUI without an ultrasound guided, effort. You don't have to have another assistant there and you can get away with it because it really doesn't matter. Unless you have a real difficult transfer, there's a history of something like that earlier. Okay, this is a good one. The bed rest after IUI, 10 to 15 minutes is recommended after one trial which was published some time back. And even the current ISHRE updates do recommend that. Now, this is very different from IVF, where embryo transfer and ambulation is supposed to have a better pregnancy rates. So in IUI, post IUI, you can make the lady lie down for 10-15 minutes. Probably it would help. I will not go into luteal support too much because there's a talk on this. But overall, in CC stimulated cycles, it's not a very good idea to load them with further progesterone. Whereas gonadotropin, definitely there is a role for adding in progesterone. I'd just like to share our data, which was way back in 2010. We had looked at some 500 cycles. Our side, we don't do donor cycles. So we were under homologous IUIs only. And we had this very strict cancellation policy, wherein we did not have anything beyond 3 or more follicles allowed for an IUI. So our pregnancy rates were hovering around 9 to 10%. But in this particular study, there were no multiple pregnancies. It gives you an idea about how strict the cancellation policies were. So the learning point in that particular study was that whenever we had one pre-ovulatory follicle, you had success of 8.5. When you had 2 ovulatory follicles, pre-ovulatory follicles, you had 13. And when you went up to 3, it went up to 20% plus. So the idea is, in an unexplained infertility, you should target more than 1. It's called superovulation. And that's but that tweaking needs to be done in an individualized manner. Again, we looked at the total motile fraction, and earlier we used to do IUI even below 5 million total motile fraction. But after the study data, we could clearly see that the results were quite poor between below 5. So we raised the threshold to 5 million and beyond, but definitely the best pregnancy rates were between 10 to 20 million. This is in agreement with the earlier studies, whatever Dr. Bahadur also has quoted, and in the studies that were there in the literature. Our experience with ANTAG was very, very, disappointing to say the least. we had very poor pregnancy rates on ANTAG, and we had to, in fact, call it off prematurely. And we did publish this way back. So the practice point, I would say that if you are in a unit who is doing IUI, if you have a lady beyond 35 or a duration of more than 5 to 6 years, it's an important prognostic factor. And if it's a good time to move towards IVF at some point of time if these two are not in favor. Um, Practicing IUI beyond 3 to 4 cycles is not a good idea because the success rates, as I have quoted, does go down. IUI should be avoided in moderate to severe male factor or endometriosis. I would urge to keep monitoring simple, no role of biochemical monitoring in IUI, even there's very minimal role in even IVF. Trigger, I have already explained, is flexible. I would say at present, it's little contrary to the whatever has been spoken earlier, but current recommendation does not suggest double IUI. Antac is definitely to be avoided. Progesterone support for gonadotropin cycles. The key what we learned from our data was if you really want to hike up the pregnancy rates, as Dr. Bahadur also has mentioned this, the key is to go for a more aggressive stimulation. How do you get that, and how do you do that tightrope walk in terms of not going overboard and having more than 3 follicles, like 4, 5 and all? That is something which is got a learning curve. There's need for a closer monitoring. And remember that for the higher the pregnancy, you will have a higher cost in terms of multiple pregnancy, and more worryingly, higher order pregnancies. Be ready to cancel if you find that somebody is hyperstimulating. But I would urge an aggressive stimulation only when you can pull off a rescue IVF. It's not a good idea without that. I would stop at that. Thank you. Yeah.
Thank you, Dr. Kamath. As usual, it was a very exhaustive and nice review. And I think we are all in dilemma of the one thing which you projected on your slide, that the follicle hasn't ruptured. Should we do an IUI or not? So that remains a dilemma with all of us. And I think we need more studies on that. I think for male factor, probably you could do a double IUI. That is what they say, that if the follicle hasn't ruptured, studies have shown, as you wrote, the male factor, that you can do a double IUI in these cases, and they have shown better results. But that is the only case in which you should be doing a double IUI.
Yeah.
Thank you so much. I think it's time for questions, and Kavita is going to take the questions.
Yeah, so first we have questions for you, Dr. Ghulam. In letrozole gonadotropin cycle, what dose of gonadotropin is to be used and from which day of cycle?
Right. I have no experience on the combined letrozole gonadotropin, but from colleagues who are using it, they're going for 75 gonadotropin and 5 milligram of letrozole. And in fact, they're getting, I'm quite impressed with some of the letrozole and letrozole alone combined and letrozole alone studies, data that they're getting. So I can't answer you specifically because we have not used, we have simply been.
Yeah. Dr. Abha, would you like to pitch in and share your experience of letrozole or gonadotropin, or only gonadotropin for?
Same with me. I don't use letrozole with gonadotropin at all. And my regime is only gonadotropin still now. And I just wanted to say that if you have a multifollicular response, the only way out is not changing the cycle into IVF or canceling it. I think you can just aspirate the cycles at the time of the LH surge starting or HCG trigger. I don't know how convenient it would be for clinicians, but aspirating out almost all follicles, leaving 1 or 2 behind, would possibly reduce the chance of multiple pregnancy and maybe also OHSS. And another thing I wanted to say over here, that it is the multifollicular response which invites a luteal support. It is not clomiphene or gonadotropin which decides whether a luteal support should be given or not, because when there are 2 or 3 follicles, then we know that a spontaneous LH surge may not be enough to support the whole luteal phase across, because some corpora lutea may disintegrate and spoil the endometrium. So just wanted to make a point here, because this is a very important point, that if you have 2 or more follicles, a luteal support becomes more important.
Okay, thank you, Dr. Abha, for the inputs. So I move to Dr. Kama. Do you look for LH levels in IUI to time it?
Say something.
Yeah,
Dr. Sonia wants a comment.
yeah. Dr. Sonia, you are muted. Ma'am, please unmute yourself.
I can ask later on. It's a question. I would ask all of them later on. You continue, Kavita.
Okay, thank you, ma'am.
Yeah.
So, Dr. Kamath, the question is, do you look for LH levels in IUI to time it?
We have kind of, yeah, we do. We were doing this serum LH and all, but now what we do is we do a urinary LH. If we find there is no surge, we give a trigger in the night. We kind of, if we find an LH surge on urinary kit, we plan it next day. Otherwise, we don't chase the serum LH too any longer. Earlier, we used to do that. After the trial, we realized we further simplified it. So we no longer do a serum LH, which we used to do when it was 17 mm and so on. We just do a urinary LH. If we don't find any surge, we go ahead. We can argue that it can still be a descending limb and all that, but overall, as I said, in IUI, these things really don't make a much impact on the ground. So we just go ahead with that. So urinary LH is enough once.
And what about sperm DFI in IUI cycles?
I'm not a big proponent of DFI at all in any ways.
I don't think any one of us would be doing a DFI. Dr. Sonia, Dr. Surveen, Dr. Ghulam, Dr. Abha.
No, I don't. The
Yeah.
position about DFI, I'm just presenting data on it,
Yeah.
but it's really not needed, quite frankly.
At the
Because
moment.
if you do what I say, use consecutive ejaculate, we've confirmed that the DNA fragmentation in the consecutive ejaculate is far less than that of the initial ejaculate. There's no point in doing DFI study because it's a very costly thing. But can I just comment one more thing? I mean, Mohan's talk was really good. But what I notice is that it remains at a 9% per cycle level. A lot of my colleagues, we have suffered in the earlier years between the 7 to 13% bracket per cycle. And we need to break out of that bracket. And to break out, we want to go from 15 to 22% per cycle. And what that is the breakout area that we need to get into. In order to do that, we do need to be a little bit adventurous here because you cannot stick to all protocols. Mohan mentioned about severe male factor. You won't believe it, but I actually enjoy severe male factor. I invite them and I do the consecutive ejaculate. I'll give you one extreme example that I've had. 4 million, 30% poor progression. 4 million, all right? That's the first ejaculate. Second ejaculate, 90 million, 80%. Wow, where did it all come from, you know? And at Homerton Hospital, when I go, I don't do the IUI, but I keep an eye out on the IUI. And because I sit in with the staff, when they see a poor sample, I said, get him to do a consecutive ejaculate. And these are independent of me. There's no bias. They'll instantly say it is far better. And their pregnancy rates
how often do you see this? How often?
Exactly.
First, the way you do it is you profile the patients beforehand for two reasons. One is, are you able to do a consecutive ejaculate? Now, I want you to do the consecutive ejaculate soon after the first, because otherwise, if you can't, I have a management problem about holding your first sample and preparing it. All right. So, in fact, most of them, if they're counseled beforehand, they will be able to do it literally, some within 5 minutes of the first ejaculate, but some maybe 20 minutes, never half an hour. Most of them will. I get this constant thing. When I spoke to Roy Homburg first, he said, are men able to produce a second sample? As a question, yes, they are, but you need to counsel them beforehand. Now, ironically, the reason why the woman's not pregnant is because of the low sperm numbers here. If she was just given more sperm, and that is what we published in Jogi, we showed that whenever we use consecutive ejaculate, it was for very severe male factor, and we could actually match the success rate to something like 19% per cycle. And these are the easiest women to get pregnant.
Isn't
Well,
the
I have been
Dr.
trying
Sonia, you wanted to ask a
Yeah,
question.
yeah.
Yeah, we can have that.
Can I just say something? I was actually talking about the DFI. There are so many patients who are actually not abstaining for very long periods. Now, especially in this part of Delhi where we are, people are not so frequently having contact. And therefore, this long period of ejaculation is what we are seeing is giving rise to this high DFI that Dr. Ghulam Bahadur is saying. And because of that, I do practice I do test each and every semen sample for DFI in my clinic. And we are practicing what you're saying, Dr. Ghulam Bahadur, consecutive samples for IVF as well as IUI, for both. It does improve the sample. And the other thing is that if you look at the DFI, we have a paper published on that. If you look at the DFI levels after repeated ejaculations for 4 or 5 days, you find that there is really no DFI. What you are saying is correct. You don't believe in it because it's all because of the stasis of the sperm in the tract that it is giving rise to high DFI over there, not anything else. That is one. So it does make sense to do it and prove it to the patient that, look, this is what is the reason. You just can't ask men to keep on giving samples if you don't have a solid proof to tell them, okay, this is what it is and this is how you're going. This is my experience. So if you show them a report and if you show them a difference between the two reports, they're very happy to give samples. That is my take on it. And that's why we always do it.
I
But
have a
technically, there is.
Practicing,
have a question for the house.
Yes,
Is the
doctor.
first ejaculate better or the second ejaculate? Mohan, would you comment on that?
The second is better always, Abba.
It's always better. The linear progression on the second one is far, as studies have shown.
In electroejaculation, what happens? It is the first ejaculate which is as good as the second, and therefore we don't go on giving electroejaculation one after the other because we know whatever we get in the first ejaculate is going to be better.
What is a split ejaculate then?
Yeah, split
No,
ejaculate.
Therefore,
that's a different. That's a difference.
Yeah, it's a different
story. That is the same time the first and the second ejaculate. But if you have two different ejaculations at different timings, that you've ejaculated once and you go and ejaculate again, like Dr. Bahadur is saying,
we are doing
different story altogether.
We are doing the same.
So, Dr. Neeti, can we wind up this session? There are two questions in the chat box.
One more question to all of you. When you're talking about categorizing your patients properly in order to improve the success rate in IUI, what about the patients that we are getting with poor ovarian reserve? Are you getting the same results in them as well? Are you doing any testing? I'm asking this particularly because it's become fashionable for everyone across the NCR to be testing the day 2, day 3 hormones. Should we be doing it for all patients, for even those we are posting for IUI? Should we be doing FSH, LH, estradiol, AMH for these patients whom we want to post for IUI? Would you be missing many patients and labeling them as unexplained infertility if we are not doing these tests?
We are doing an antral follicle.
Just an antral follicle that's what I want this to be answered by the three.
I think we do the baseline estradiol in our gonadotropin IUI cycles to rule out any premature follicular selection.
What about the three? I want this message.
The rest all not. We are not doing it.
The participants.
Do a baseline FSH and E2 once to know whether there is any evidence of POI setting.
That's what. So we do need to do it.
Once we do it.
FSH, AMH of 0.5 nanograms will
I don't think Mohan agrees with that.
No, I don't agree.
That's what I'm saying. So we need to have this message.
You can have an AMH of 0.5 nanogram and you can still have FSH of 30 MIU. And that surely pushes the patient into premature ovarian insufficiency and you would have very poor results. So I think a baseline FSH once is important. We don't need to repeat it every cycle. Just
of course not.
A couple of questions. Just one thing. Of course, we don't do any of this. We heavily rely on the AFC. And as Dr. Bahadur did point out, I just want to tell one point. In that study which we quoted, which is 9 to 10% pregnancy rates, there were no multiple pregnancies. So it basically, because we have patients who come from far off, so we can't have a hyperstimulation and they go home and have twins and triplets because they come from very remote areas. So as I wanted to point out that it's up to your clinic, what kind of patients are we handling? That will decide your aggressive strategy, stimulation strategy. So if you
And
are
you
those,
showed that you had 3 follicles also, and your
yeah,
pregnancy
ma'am. So
rate
that
went
obviously
up.
the
How many
strategy would
multiples
decide, it will decide how aggressive. I could actually make 50% also aggressive. Like that's what we had to decide how fast, how far we want to go.
So what
That's
was
the
the
key.
multiple pregnancy rate in that group which showed a much higher pregnancy
Yeah,
rate?
yeah.
What was it?
So much.
That was mainly unexplained. Yeah. Yeah.
No, was there a multiple pregnancy rate when you had 3
No,
dominant
no,
follicles?
no. But those were very few patients, ma'am. There's 3, 4 only. That's why. Yeah. Yeah.
Dr.
Can I
Ghulam,
just add that this
Yeah.
notion that if you have a higher pregnancy rate, you're going to have a higher multiple birth rate.
I agree with this 100%.
Away from it. Clinics that are learning to control it are controlling it very well. Our clinic is controlling it so well that we have one of the lowest multiple birth rates. Lowest, I mean, there's really one of the lowest ones. And in my paper on in the BMJ Open, I also point out how multiple births in IVF are being controlled by fetal reduction.
Yeah.
You know, something that never actually crossed people's minds in a
Yeah.
big way. And we have now shown that data. And remember, we gained this data from a Freedom of Information Act. So there was no bias from us in selecting what data we could and could not comment on. That data was given to us. We asked for it and they gave it to us. And it took several months to get it.
Thank you.
We can wind up the session here, and the rest of the questions will be covered in the future lectures and the panel discussion. We are running out of time. Is that
And there are 2 questions in the chat box, so I would ask the speakers to just have a look at it and comment on it. Thank you so much.
Thank you so much.
Dr. Niti, to you.
Thank you so much, the speakers and the chairperson, for the wonderful session. I'm sure the delegates and we as well have gained a lot from this session. And we move on to the next session now. So for this session, I would like to invite the chairpersons, Dr. Kanika Jain, who is the senior consultant gynae endoscopic and robotic surgeon from Gangaram Hospital. And she also is the vice president of AOGD. Dr. Jyoti Bali, who is the director of Baby Soon Fertility and IVF Center. And Dr. Shalini Chawla Khanna, who is senior IVF and laparoscopic consultant with Max Hospital, Delhi and NCR. So over to the chairpersons for the next session.
Should I try?
Dr. Shalini, you're muted.
Yeah. Thanks, Niti, for the kind introduction. It's my pleasure to invite Dr. Tanya Bakshi. She's the principal consultant, IVF, reproductive medicine and surgery and onco-fertility. She's associated with the Max Super Speciality Hospitals, Delhi and Gurgaon. Over to you, Tanya.
Thank you, Shalini. I'm just going to screen share in a moment. Can you see my slides?
No.
Yeah, we could. Just make it full screen.
Just doing that. Yeah. So first of all, I'd like to thank the AOT team for my seniors. Just being here, my colleague Shalini. I have Niti, Shweta, and Kavita, my dear friends. Thank you.
Your voice is breaking, Dr. Tanya. I don't know.
Can
hear everyone hear?
No, it's breaking.
No, it's breaking.
Can you hear me now?
It's breaking. Yeah.
Okay, just a moment. Can you hear me now? Is it better?
Yeah.
Yes, now it's okay.
Yeah.
Okay. So just moving on, and My slide is not going, just 1 second. Okay, so a very pertinent topic. Thank you for having that. The medical legal aspects of IUI. We've had a really nice discussion, and I think we still have challenges to overcome. And again, medical legal are another bunch which fits into that category. So I'll start off by saying that why are we really talking about law and ethics? We know that the legal issues are on the rise. We face a new challenge now with moral and ethical issues, be it with the COVID pandemic and restarting of our clinics, be it with the new norm where we can have single parents, be it with the posthumous use of gametes or cases of adultery. We've all had patients where they come and say, we can't produce on site, and then they come with their husbands and they have a pot of semen in their hand, and God alone knows if it's theirs or whose sample it is. So we're just going to cover a few aspects. First of all, what is the code of practice? I think we're in an era where we all should know our guidelines and we should follow our guidelines. There are international guidelines and there are local guidelines. I think Good News was fantastic as a movie, but when it comes to any of us, I know it's not good news and we should avoid it at every cost. So we should have an optimal team and a setup. We should ensure confidentiality, both of the commissioning couple or the single woman and even of the donor. We should have written consents. We should have complete documentation. And I think this is one area where more is less. Get as much as you can rather than having less documentation, have as much as you have. You never know what may be needed and when it would be needed. Record keeping. We have to be very good with our record keeping. We should have double witnessing in the lab. We should adhere with the donor bank guidelines. And whenever in doubt, seek help. I think we have so many webinars now. We have so many seniors. We have so many people to guide us. I think it's not an age or an era where if in doubt, stick to yourself. If in doubt, please seek help. Now, really, the ART guidelines we've been going on since 2010 started really with the accreditation and supervision of both the clinics and the bank. And this was mainly to ensure the ethical practices and ethical services to be provided, and that medical, social, and legal rights of all concerned should be protected with really maximum benefit to the couples. So again, really moving on now, we've got so many guidelines. We have, I would say, with the COVID pandemic coming up, we've got the new guidelines as a joint statement from both the ISAR, IFS, and we have all the consents there in place with also in depth of how we should counsel our couples. We have the IFS coming up. It's a dynamic website. So we have the fertility statements, which are being regularly updated. And we have the new ART regulation bill, which has also come up recently. So what are the dilemmas and challenges really with the documentation? I think this is something, again, which all of us have to look at. Are we happy with just an Aadhaar card? We know sometimes people can make an Aadhaar card very fast. Is it authentic? Do we get a marriage certificate? What about if a single woman comes? And what are we going to do then? Is it okay just to have her documentation? If she has a nominee, I think we should get all documentation of the nominee as well. Then what about welfare of the child? I think what we cannot forget, whatever we do here in ART is always at the backbone. What is the best interest for the child being born? What about home collection samples? We must have robust documentations in place. We must have separate consents for home collection samples. And we must explain to the couple that it is not only how it affects a sample and when we give them guidelines how to collect and how to get an optimal home collection sample, but also from a legal perspective. We must ensure the best outcome for the couple and for the clinic and the doctor as well. What about COVID testing? I think the guidelines are very clear, but is everybody following it? Is everyone doing the RT-PCR? Are we doing the antigen test or are we doing nothing? As we said, India is such a wide country. We are in South Delhi. We have from South, we have somebody in the outreach clinics where we may not have their facility. So what should they do? In today's era, what are we looking at really? And what is it just legal to save ourselves? Or is it the best outcome to give the couple the best outcome? What about posthumous use? More and more we are getting requests for posthumous use, be it with the oncofertility going up, be it where people are more aware. We could have accident victims coming up to us. So we have to have our documentation clearly addressing this. I mean, when I started 8 years ago, we have consents where we've not got anything. We've not tackled this discussion to now where we take a moment and we have a detailed discussion specifically for this question. So I'm not going to go in details about the ideal team. I'm going to move a bit about the donor bank and a bit about record keeping. So as we know, the record should be maintained for a period of 10 years, and later the clinic shall transfer it to the ICMR registry. In case it's closed, then we have to move it to the central database. So really with a sperm bank or a semen bank, again, the ICMR guidelines are very clear. What I would like to say is what really is expected from the donor bank and what really is desired. So of course, it should be registered, it should be professionally run, it should follow the ICMR code of practice, it should have its SOPs in place for prior preservation, it should have the consents, it should have the record keeping. And really what is desired, all of these above, along with your ideal team, it should be transparent. In the real world, we would be doing the commercial DNA fingerprinting of all the donors, be it the sperm donors, oocyte donors, or the surrogate. In the ideal world, we should be doing karyotype and genetic testing. What we do really right now is things like thalassemia we're testing for. We should have a comprehensive infection screen. We should not only look for the HIV, hepatitis B, C, VDRL, but potentially for CMV, for chlamydia, and there should be external audits. Again, we have to ensure confidentiality. We have to have a detailed donor performer. We should have our SOPs in place. We should have our consents in place. The certification and the testing for these donors should be from certified, either an ISO or NABL accredited labs, because remember, it's very important. We are trusting them to give us the best valid reports. We should have a qualified team to perform semen freezing. For us, the samples here, we say they should be cryopreserved for at least 6 months before the first use, and we have to screen them for the sexually transmitted diseases and for hepatitis B, C, and HIV. Semen from 2 individuals should never be mixed under any circumstance. The sperm bank should not supply semen of 1 donor for more than 10 successful pregnancies. But if you're not going to inform them or we don't have a record, how do we really manage the 10 pregnancies is yet another question to be answered. They have to keep a record of all the samples received, stored, supplied, and the use of each. And they should ideally be liable to a review policy by an accreditation authority. Keep the records for 10 years, as I've already said, and 1 sample for only once on 1 recipient. And the responsibility is either the ART clinic or of the patient to inform of a successful pregnancy. Do we do that? I think that's something else we have to make sure from our clinic it happens. Again, it is the responsibility of the ART clinic that we obtain it from appropriate banks and not fresh and not direct. Neither the clinic nor the couple should have a right to know the donor's identity or the address. However, both the clinic and the couple have a right to know the fullest possible information. We can know everything, right from the height, weight, skin color, education qualifications, family background, and of course, freedom from the diseases or carrier status of hepatitis or AIDS, their ethnic origin, before accepting the donor sample. This is just a summary of what I've just spoken about. So, you know, at the time where Wikidonor came up, it became as if it's the new profession on the block. We had even young schoolboys coming up and saying they wanted to be a sperm donor. I started receiving calls. I'm sure all of you would have random calls from people saying, okay, I want to be a sperm donor. How much will you pay me? And I think the important part here is who can be a sperm donor. We have the guidelines here, and I just say that we are saying not below 21 or above 45 years. However, the ART draft 2020 says 21 to 55 years, which again, I think we can debate and chat about later. but I'm just putting the points across. They should be free of HIV, hepatitis B, C, and sexually transmitted diseases, free of hypertension, diabetes, free of common genetic disorders like thalassemia, and should not be a known friend or a relative. So what are the legal issues? Now, adultery comes up as a topic. Now, if ART is used for a married woman with the consent of the husband, it does not amount to adultery, even if she is using a donor sample. However, if you don't have a consent with you, then it can be a ground for divorce or judicial separation. What about annulment because of consummation? Now, that's a bit of a tricky topic, and the wife can take it to the court and can fight about decree of nullity, but I think that's a sticky ground, and that would again depend on who fights which side well. What about an unmarried woman? She can very well go ahead and she can take a sample and can be the legal mother. However, ICMR also states that ideally it's a two-parent family, which would always be better. So I think, again, this is something which is contentious, whereby there are enough women who are good parents. And again, what we must remember, it is the child's interest which must outweigh all other interests. What about posthumous use? A child born within 280 days of dissolution of marriage by either death or divorce is a legitimate child, as per the ICMR 2010, and very clear guidelines. You can only collect the sperms posthumously if you have prior consent of the commissioning couple. So I think each of us have to be very mindful now when we take consents and how we are storing these consents. So recently I had a patient, and the wife was not there, and he made her as a nominee. Now the wife wants to claim this sperm. There is no consent, there's no signature, and it would be very difficult. Again, it would go through the court, and that would be the decision factor. But as per the new guidelines, you don't have a consent of the couple, because it's not just about creating a new life. Remember, there are further legal implications which go on to inheritance as well, especially in our country. So moving on to forms, I think if this was a panel and if I had a show of hands, I would ask all of you to raise your hands and tell me which form we all know and how many forms do we fill in. So I will just go ahead, unless if I can ask at the end. Shweta, do you know what a form L is, or Neeti, or Jyoti?
Absolutely not. I only know one consent form.
Well, I'm glad, and I hope everybody does look through this. And it was quite interesting how many forms we have. This is actually consent form for the donor sperm. There's a form M for information of the semen donor. There is a form O, which is record of use of donor gametes or the surrogate. There is a form R, which is the contract between the ART bank and the semen donor. Please be very mindful that your clinic has that, because this is something which can save you. A form S, which is a contract between the ART bank and the patient. A form T, which is a contract between the ART bank and the ART clinic. And there are tons more. So I'm just going to say I've given you a list. And what I found very interesting, that there is a form V, which is oath of secrecy. And I'll be very honest, neither have I ever filled it. But when I looked at it, it is so interesting that I think our consent forms are going to be that big. Because if we're going to get the consents and they're all there, they're out there, we have to be educated to use them. So what about COVID? And that puts in another angle, because we not only need another consent, we need to explain to the couples what we are doing, how we are testing them, and what is in their best safe interest. Again, we've got the consent already there with the joint ESAR IFS. All of you can look at it, download it, and please do have this as well and add this on. This is how a form Q, which is the semen analysis report, looks like. I've just got the forms to show you. This is the form E. This is which is going to be using with husband's sperm. This is a form F, as you can see, with donor semen. This is what it looks like. This is the form L, which is the consent form for the donor. Now for single woman, I've just showed you a draft of what we have. I'm not sure if each of you has it, but at our unit, we really do a lot of paperwork, and I think we put in a lot of time and effort to develop a quality control for our documentation and consents. What I'd also like to show you that we have something called a donor sperm criteria, whereby they put down all their requirements, and then we get the lady to sign a witness from her side and a lab witness as well, which is then put into the consent form as well, while getting as per her specifications. So this is something, if you haven't seen, all of you should look at again. It's quite a robust form. And I think after this, it's something interesting. I would like to ask the donor bank to show us a few, at least I would want to know. So this is quite detailed. As you can see, all the information on the sperm donor, a very detailed history, a very detailed examination. Now in testing, they're doing blood picture, blood group, random sugar, creatinine, just the PT, urine, then you've got the infection screens here. Then you've got the height, weight in the physical examination, as you can see, that's the rest. And this has to be carried out every 6 months.
Dr. Tanya, sorry to interject, but you will have to finish in another minute.
Yes, I'm finishing. I've just got a couple of slides. This again is how the results of the screening are put. And as you can see, the second date is 6 months from the first testing. And this is the form which is then only after it's done and you've ticked it off as being acceptable, will the person be go ahead and become, whether it's a sperm donor, oocyte donor, or a surrogate mother. This is the form N. This is the form V I was talking about, the oath of secrecy, as you can see, which actually we've got to do. And I'm just putting in the BFS, the British guidelines, which are slightly different to ours. And again, it's a nice read. And it's important because their age cutoff is different. They're far more intense in testing their donors, as you can see. This is a very nice guide about giving consent. And again, I'd get everyone to look at it. So I think I'm all done. Thank you. What is important is take as much. If you're in doubt, get more. The other thing that we started doing is that if you've got a couple, take a picture. So just like we would do for IVF. So if you have a man and a woman, when they come to you and they said, this is our Aadhaar card, we are married, along with their marriage certificate, take a picture as well, because there are times where we've had women who come with either their friend or a boyfriend and they give a sample. And I think we've got to be very clear. Keep all your records, keep all your documentation. Please explain to them, as so nicely our previous panelists have explained, what is the outcome, what are the success rates, what are the risks. And I think if we've done a very good counseling, we've maintained our confidentiality, and we are true and transparent, I think legal disputes and legal issues would be far and in between. Thank you. Thank you, Shalvi.
Yeah. Thanks, Tanya, for giving such a wonderful insight into such a controversial topic. As we all know that the legal issues, especially with the ART banks, we all read it in the ICMR guidelines that the samples are to be tested again after 6 months before they provide us the sample. But how far these guidelines, these banks, they are following, truly, it's still we yet to know and be clear on that. And there is another question for you, Tanya. What consent do you take for sperm preservation in oncofertility? And what happens in the case of a death of an unmarried patient or a married male partner?
So for oncofertility, we have special consents. We've made them only for the oncology patients. Again, it's very much similar to the consent that I've showed you, except where we've added in where for oncology patients, this question of what do we do with your gametes after death? I think that's very important. And we've put in 2 separate forms, one for the unmarried. If they're unmarried, there's nothing, unfortunately. The only option is to use it for research or to discard, because really nobody else can use their gametes. So I've had a young boy who was 19, and after his death, his parents wanted it, and there's no way we can give it. For a married person, if the wife is there and if she signs on it, then she could potentially take it. But again, he can choose to give it for research, discarding it. But remember, it gets very tricky if we don't have these consents in place. So for oncology, we have a specific consent, which is for the oncology, as I showed you for the single women. So in our unit, I've had special consents for oncology, and we look at the posthumous use exactly in this. Yeah, and I think we started this for the last 3 to 4 years. Before that, we didn't have that, but now we are taking it.
Okay. Yeah.
Tanya, can we ask for a marriage certificate? It is practically possible in the clinic to ask for a marriage certificate.
Yes, Jyoti, yes. We do that. We ask everyone for a marriage certificate, because if you're going to do IVF, you're going to do the marriage certificate then as well. So to my mind, if we are treating, we're not separating. So as the new guidelines are saying, ART is ART. Now, if we are going to perform a procedure, be it an IUI, if you're handling gametes, I think we should keep ourselves safe. If you have the provision, if they can't give it, take a picture. If you can get, so if you can't get a marriage certificate, for example, she has an Aadhaar card which says, I'm Tanya, wife of Nitesh, that's fine.
Aadhaar card is yes.
Yes, if she has, if she doesn't, a passport, or sometimes we even ask for a legal document. So for example, a tenancy agreement which is certified, something which states they are husband and wife. If two people come across and they have no documentation to claim he's my husband, then we are not happy with that. So we would go ahead, and if they don't have, then we would ask them to get a legal affidavit made stating that they are man and wife. So Jyoti, for us, we are very clear. They have to have some form of a legal document stating they are man and wife.
No,
otherwise we don't take it.
Thank you so much, Dr. Tanya. I
Thank
think
you.
now I'll ask Dr. Jyoti to introduce Dr. Rashmi.
It's a proud privilege to introduce Dr. Rashmi Sharma. She's Director of Origin Fertility and IVF at New Delhi, and she's also the Joint Editor of Indian Fertility Society. Over to you, Dr. Rashmi.
Unmute yourself, Dr. Rashmi. Unmute yourself. Unmute yourself.
Right. All right. Are you able to hear me?
Yeah,
Yes.
we can hear you.
Okay. So I'll just start sharing screen. Can you see my screen?
Yes.
Okay. So now the topic for today is luteal phase support after IUI, a practical approach. Okay. So the questions that need to be answered are, is there a role for luteal phase support in IUI cycle at all? And if yes, there is, then whether it is needed in all types of IUI cycles, and then if yes, then what type of support is indicated? And then we have to review the evidence whether we are justified in giving luteal phase support to the IUI patients. So just a little bit of, a very basic physiology. What is luteal phase? Luteal phase is defined as a period between ovulation and onset of menses. We all know that, or the establishment of pregnancy. And the usual duration of luteal phase, or the ideal length of luteal phase, is 12 to 14 days. If the luteal phase is shorter than that, then we know that there may be some luteal phase defect. We know luteal phase is depending upon the corpus luteum, which is a very temporary endocrine gland, which develops after ovulation from the ruptured follicle. We know because of the mid-luteal increase in the LH, which is there for ovulation, the granulosa and the theca cells are converted to the luteal cells in the follicle. And that is what gives rise to corpus luteum. And the main function of the corpus luteum is secreting progesterone. Progesterone, we know, is absolutely essential for maintenance and establishment of pregnancy. It is a pregnancy maintenance hormone. No pregnancy can survive in the absence of progesterone, and that's how the anti-abortion pills have come. If you give anti-progesterone drug like mifepristone, pregnancy cannot maintain itself. So as such, corpus luteum and its product, which is progesterone, is very, very important for establishment and maintenance of pregnancy. So for a normal luteal function, what is needed? So we know there is a physiological continuity between the developing follicle and the corpus luteum. It's not the corpus luteum itself. We have to see prior to that also. If there is a nice developing follicle, then only it will develop into a nice working corpus luteum. So if we improve ovulatory follicular, that is likely to improve the corpus luteal function also. So a normal luteal function in any cycle, be it a normal tricycle or an IUI cycle, it will require an optimal pre-ovulatory follicular development. If the follicle itself is not optimum, it has ruptured at a lesser size, then of course it will not form a good corpus luteum. It will also require enough estrogen to induce progesterone receptors in the endometrium. So if the follicle has not secreted enough estrogen, and so the progesterone receptors will not be there in the endometrium, and the luteal phase may be defective. For it to become active, you need proper luteinization of the granulosa cells so that enough progesterone is produced. And a very, very important thing, which makes the basis for luteal phase support, is continued tonic LH support. We have to understand that the corpus luteum, which is there, it is getting a support from the LH, which is released from the pituitary. So if somehow pituitary does not secrete LH, then this corpus luteum can go into early luteolysis. That forms the basis that why in IVF cycles we see luteal phase defect. That is the reason that I want everyone to remember that if there are multiple follicles developing, those multiple follicles will lead to a lot of steroid development, and that steroid will have a negative feedback effect on the hypothalamus pituitary axis, leading to decrease in the LH secretion. And now when the LH is decreased, the corpus luteum will go into early luteus lysis and leading to luteal phase defect. So this is just a basic physiology. Now coming to luteal phase defect, we know it is a condition where endogenous progesterone is not sufficient to maintain a functional secretory endometrium, and it does not allow normal implantation and growth of an embryo. And this kind of defect or deficiency, luteal phase defect, can result from either a decrease in the amount or the duration of progesterone secreted by the corpus luteum. That means the corpus luteum is not very active and either the amount is less or the duration is less, or it can also be because of the lack of adequate response by the endometrium because of the decrease in the concentration of progesterone receptors. And how can we diagnose luteal phase defect? When the luteal phase is shorter than 11 days, that is short menstrual cycles, and after ovulation the days are less than 11, that gives a clinical indication that maybe this woman is suffering from luteal phase defect. And on the endometrial biopsy, there is a lag of more than 2 days in endometrial histological development. Of course, no one is doing these days. And sometimes when we measure mid-luteal progesterone values, if they are less than 10 nanogram per ml, then also that that kind of proves that this lady may be suffering from luteal phase defect. So this is the same that this chart is explaining the same, that why in controlled ovarian hyperstimulation, if there is multiple follicular development, it may lead to luteal phase defect because there is supraphysiological hormonal environment which inhibits the LH release via the by inhibiting the hypothalamic pituitary axis, leading to low mid-luteal LH levels. And because of that, there is premature luteolysis and decreased progesterone level and leading to luteal phase defect. Now coming to the question of IUI per se. So we know that effectiveness of luteal phase support in IVF cycle with GnRH agonist or antagonist, whatever type of IVF cycle, is very well documented. So in IVF, there's no doubt we have to support the cycles with luteal phase, but in IUI, there's lack of robust data. So, before reviewing the evidence, let me just comment on what are the different drugs used for luteal phase in IUI. Of course, we are not using any injections, though we can use, but of course not HCG, not IM progesterone is not being used. What is routinely used is either vaginal micronized progesterone or oral dydrogesterone or vaginal progesterone gel, which is 8% gel. These are the different drugs used in the luteal phase in IUI. So before commenting on the review and the evidence, let's just have a cost analysis for if we decide to give a patient luteal phase support. So around 17 days of luteal phase support following ovulation. If we use vaginal micronized progesterone capsule, the most popular brand, the cost to the patient would be approximately 935 rupees. If you decide to use vaginal 8% gel, the cost to that patient for this support would be to the tune of around 3,383 rupees. Dydrogesterone, if you use a brand one, which is an expensive one and the most popular one, the cost is about 2,284 rupees. And a brand two, which is a cheaper version, recently launched, will still cost the patient 1,700 rupees. So whatever kind of luteal phase support we use, we are adding cost burden to the patient, and the least is 935 rupees. So we have to really think twice whether we are justified in giving luteal phase support in cases of IUI or not. So now coming to the review of literature. First of all, there are hardly any studies for luteal phase support in IUI. There are thousands and thousands of papers on IVF, but for IUI, somehow this is a very neglected area. So I have arranged these studies according to the year-wise. The first study in 2009 by Erdem. So they did this study randomized control trial on 427 IUI cycles in unexplained infertility. They used recombinant FSH for IUI stimulation. The luteal phase support was with the help of gel, and their conclusion was that live birth rate favored luteal phase support, that is 35% in supported cycle versus 18% in unsupported cycle. Okay, so according to them, if you're doing IUI with recombinant FSH, it might be helpful in adding progesterone gel. But let's go further. Cairo in 2010 did a study, randomized controlled trial of 468 women with clomiphene cycle. And, I could only see one study on clomiphene, another one on clomiphene plus HMG. Otherwise, there are hardly any studies on oral drugs and evaluating the role of LPS. Okay, so their conclusion was they used micronized progesterone vaginal daily, 200 mg thrice daily, and they said there was no difference in ongoing pregnancy rate, that is 8.7% versus 9.3%, whether you give support or whether you don't give support in clomiphene cycles. Then in 2010, Ebrahimi did a study of 511 IUI cycle with unexplained infertility. They used vaginal pessaries, and the stimulation that they used was CC plus HMG. And the conclusion was that it does not have any beneficial effect. So their conclusion was LPS does not help in pregnancy rates. Then in 2011, Meher et al. Did a randomized control trial of 71 women of heterogeneous infertility. And they used recombinant FSH. And as the earlier study, they also found that the live birth rate was better when you, when you gave LPS. So support, the pregnancy rates are better. That's what the trial said. In 2012, Aga Hosseini did a study of around 290 patients, unexplained and mild male factor. Ovarian stimulation was not very clear from the abstract that what kind of ovarian stimulation they used. The full paper I could not get a hold on. They used vaginal suppositories, and according to them, they found a significantly higher clinical pregnancy rates with luteal phase support. Okay. But now coming to the latest trials, later on trials, NITO in 2014, a study of 893 IUI cycles, recombinant gonadotrophins, they used vaginal progesterone 200 mg once daily, found that there was no significant difference. Whether you give LPS or whether you don't give LPS, this was in cases which were stimulated with recombinant FSH. So it's a very contradictory study, contradictory to the earlier one. Then this study in BRAC in 2016, they studied gonadotropin plus IUI around 100 patients and clomiphene plus IUI around 100 patients, 50-50 in study and control group. They gave vaginal gel 8% daily, and they found that there was absolutely no difference in pregnancy rate. Okay, so this is also in contrast to the earlier study that even if you are using gonadotropin, there was no difference in the pregnancy rate, whether you use progesterone or whether you do not use progesterone. This study in 2016 randomized multi-center trial of around 393 normo-ovulatory patients. This was also gonadotropin cycles, and they found that there was a trend towards higher pregnancy rate as well as live birth rate when you give luteal phase support, but the difference was not statistically significant. And this is a very, very latest trial in 2020, 87 patients, gonadotropin cycle. The patients were of unexplained and mild male factor. LPS was given with vaginal progesterone, and they found absolutely no difference in clinical pregnancy rate. So there is a confusion. Earlier studies with gonadotropin cycles will say that there is a use in giving LPS, and the latest studies are saying that there is no use. So data is yet to be. Now coming to the meta-analysis. This was the first meta-analysis which came in 2013 by Hill. This was also shown by Dr. Mohan. This was of 5 trials.
Dr. Rashmi, just 2 minutes left for your time.
Okay. So this meta-analysis said that it may be of benefit. The LPS may be of benefit with gonadotropin cycle, but the progesterone support did not benefit patients who were going ovulation induction with CC. Then meta-analysis came in 2014 with exactly the same conclusion that support may be helpful with gonadotropin cycle, but is not helpful when you use oral stimulating agents. And another meta-analysis in 2017 by Green is also stating exactly the same same thing of about 4065 cycle, that it is beneficial to patient undergoing ovulation induction with gonadotropin. Number needed to treat is 11 patients to have one additional live birth if you decide to give LPS to gonadotropin cycle patients. But progesterone support did not benefit patients who are undergoing ovulation induction with clomiphene or clomiphene plus gonadotropin. Sadly, there are no studies for letrozole. So did not find any studies of LPS in role of HCG in IUI or role of LPS in letrozole cycle. And what about dydrogesterone? So dydrogesterone, we know that it has come in a big way in the IVF cycle. Lots of trials, Lotus 1, Lotus 2 have now proven that dydrogesterone is not only equal to micronized progesterone, but also a little better. So this is a very latest trial in 2020. This is a retrospective study actually by Mustafa, dydrogesterone versus micronized progesterone in IUI, stating that they have similar pregnancy outcomes. So if you decide to use LPS at all, so whether you use dydrogesterone or whether you use vaginal micronized progesterone, we might be using any. So practically, my approach would be that if there are only 1 or 2 follicles, especially with oral ovulation induction agent, avoid giving any LPS, because we want to avoid cost and we want to avoid inconvenience to the patient. There is no evidence that it helps in improving the pregnancy rate, unless there are some indicators of deficient luteal phase. Clinically, if you find there are some indicators, and indicators may be that the follicular growth was poor and it ruptured at a smaller size, then you know the corpus luteum may not be good enough. If the endometrial response was poor, if there is history of premenstrual spotting, so from the history itself, you can find out that this patient's luteal phase is defective. So maybe this patient might be helped with the use of progesterone. Or if there is a history of short luteal phase, or if somebody has measured the progesterone level and they have been found to be low, maybe these are the indicators where you might like to add luteal phase support.
Dr. Rashmi, you will have to complete.
Yeah, that's the last slide.
Yeah.
So if multifollicular response, especially in gonadotropin cycle, LPS may be justified based on still not so robust data, but also based on the experience from IVF cycles. Thank you. 1 or 2 follicles, luteal phase support is not justified. If there are multifollicular response, then yes, it may be justified. That is the crunch of the presentation.
But in our private practice, aren't we using luteal phase support for all the IUI cycles?
We should not. We should not, because of course the cost is too high. If we use dydrogesterone, the cost is around 1,700 to 2,000, 3,000 rupees. Even for the micronized vaginal pessaries, it is not less than 1,000 rupees. So, and we are not helping the patients at all. We are adding the cost burden and we are adding the stress of having the tablet. So looking at all this evidence, very, very clear. If there is only 1 or 2 follicles, there is no need for luteal phase support. And otherwise also, the basic physiology tells us that luteal phase defect will happen if there are multiple follicles leading to high estrogen levels, leading to less LH release from the pituitary, which allows, corpus luteum not to function. So theoretically also, if there is only, in fact,
Dr. Rashmi, in your IUI pregnancies, if you have given a progesterone, when do you withdraw it?
See, my practice is after the rupture. If I have to give, mostly I don't give unless it's a gonadotropin cycle. Yeah. If I have to give, I will give it for 17 days, then do a pregnancy test. And if it's positive, we continue. If it is negative, then withdraw.
Yeah, you continue till when?
Till 9 weeks. Till 9 weeks. Till the placenta takes over.
And Dr. Rashmi, you have compared in your chart, you compared single dosage of vaginal suppository, which you're...
That is 400 mg.
Okay, so that you were giving, do you give suppositories only once a day?
Once at night. Once at night, if it is 400 mg. If it is 400 mg, that once at night, but if it is 200, then you might like to give twice a day. So there was one study on micronized, in the gonadotropin cycle where they did not find any evidence. They had used only 200 mg once a day. That may be one of the fallacies of that trial, that maybe they used a little lesser dose of progesterone.
No, but on
Dr. Rashmi, I guess 400 is not a physiological dose required. Do you really feel you should give 400?
Ma'am, the most of the studies they have used 200 TDS or 200 BD, and in some of them they've used 400 OD. Most of the studies.
They have a short life. I feel.
Can I make a comment here?
Yes, ma'am. Yes, ma'am.
I feel medicine has its own half-life, and hence a vaginal tablet is best used in twice in 24 hours dosage, whereas oral micronized tablets were not effective even if they were used every 4 hours. And an injectable has a longer half-life, and therefore it can be used in a once-a-day dosage. So using a dosage, whatever the total dosage is, has to be divided into 2 parts if used vaginally. I mean, otherwise people have used luteal phase. You are not advocating luteal phase. So doses don't matter whether you use 400, 200 or you don't use at all. The results are same. But if they have to be used, it's better to use according to the half-life span of usage.
Thank you so much, chairpersons and the speakers, for a wonderful session. I'm afraid we'll have to move on. So we'll move on to session 3, which is a very interesting session of panel discussion. I will request Dr. Ruma to introduce the moderators.
Good afternoon, everyone. I'm going to introduce my dear friends and colleagues for this session. Dr. Shweta Mittal Gupta, you already know, she's the prime driver behind this workshop and a senior consultant at the Center of IVF in Sir Gangaram Hospital. And Dr. Neeti Tiwari, my dear friend and colleague again, also a senior consultant at Center of IVF and Sir Gangaram Hospital. Both of them together are going to moderate a stellar session on case-based scenarios on ovulation induction and IUI.
Thank you, Dr. Ruma. So we'll start our panel right away. I want to invite our panelist, Dr. Nagori. He is director of Dr. Nagori's Institute for Infertility and IVF at Ahmedabad and has plenty of books which are published. Dr. Manish Bankar, Medical Director, Nova IVF Fertility, one of the largest IVF groups with multiple clinics. We have Dr. Madhuri Patil, Clinical Director of Dr. Patil's Fertility and Endoscopic Clinic, Bangalore. Do we have Dr. Madhuri with us?
Yeah, she's there.
Oh, yeah.
She's there.
Dr. Leena, she's professor and IVF in charge of Department of Obs-Gynae, ESI, Vasai Dharapur. So I wanted to just tell that in our panel, we will have two panelists who are from government sector and the ESI sector, and then we will have panelists who are absolutely from the private sector, and we will be getting, view from all of them. Dr. Priya, she's consultant head, Department of Reproductive Medicine, Bansal Hospital, Bhopal. Dr. Priya will have to possibly move out earlier, so a few cases which we had designated for her later on, maybe we will, involve her in the beginning part. And Dr. Piki Saxena, Professor of Obstetrics and Gynecology, Lady Hardinge Medical College. So when we are talking about IUI, now we have heard so much, we are very wise. Now let's come to the practical application of what we know and what new we would be adding for our delegates. IUI is the most common reproductive treatment practiced by infertility specialists. I remember the moment we set up a clinic, the first step we take is setting up an IUI facility, and that is called the level 2 care. And if we are really mastering in it, and in China, I know the rule that in China, you cannot set up an IVF facility unless you have a particular pregnancy rate, which you would be showing from your IUI facility. It is less invasive. It seems pretty easy to learn and perform. It's inexpensive. Minimal equipment is required. And there has been a constant effort to improve the outcome of IUI by combining IUI with ovarian stimulation, modifications in sperm preparation technique, and optimizing the timing of IUI, which we realized in our previous, all the talks. But the results vary grossly from center to center, and this is what we are here to learn, that how do we optimize. So this is a case for Dr. Manish Bankar and Dr. Priya Bhave, but we would be very delighted to have other panelists to pitch in too. So she's a 32-year-old female, married since 4 years, and she started trying conception for last 2 years. Menstrual cycles were regular. She's hypothyroid. Father is diabetic. Now, previously, she had history of documented ovulation with 3 cycles of ovulation induction with clomiphene and timely intercourse. AMH 2.5 nanograms. HSG bilateral tubes are patent. Now the semen analysis, which was performed as per the WHO 2010 parameters, 12 million count, 40% motile and 4% normal. A second semen analysis report again said for 14 million and 60% motile and 5% normal. So my question to the panelists, that is the diagnosis male factor infertility in this case? Dr. Priya, Dr. Manish, anybody can answer.
Yeah, Shweta, I agree with you. Basically, whenever we look at WHO 2010 criteria,
yes,
we have to remember that they're not normal ranges, they are reference ranges, and the fifth percentile is 15 million. So, although a person who may have 14 or 15 million, we might feel that he is just at the limit, but actually 95% of the fertile men have counts over his value. So 14 million, definitely it is a mild male factor infertility according to me. And these kind of counts also 12, 13, 14 million, actually they reduce the cycle fecundity in my experience.
What are your views? So Dr. Priya, would you be offering an IUI at this juncture to this patient who is young, has been trying for last 2 years?
Yes, I think IUI is a good option for them. She's young, her ovarian reserve is good, she is obviously ovulating. So I think IUI is a good option for this couple.
Dr. Banker, are you there?
Yes, yes. I agree.
So what are your views on this?
I think I agree. This is a patient having a mild male factor, and possibly IUI would be the preferred treatment of choice for this particular patient. She is not so young, not so old, 32 years, but with a good AMH, rest everything normal. So I would certainly offer her IUI.
Dr. Nagori, what are your views on this?
Definitely, 100% I'll go for IUI.
Okay, so Dr. Madhuri, do you also agree to the same?
Yes, yes, I would agree to the same, that we would go for an IUI. In this patient, because it's borderline, I would also like to do a post-wash trial post-wash to know what the post-wash count is, because we can do an IUI if we have a good post-wash count of 5 million after the sample. So that would really tell us this thing. And I also at times like to do a 24-hour survival, because that also then tells us, because many a times if there's a compromise, it's a mild factor, and if your 24-hour survival is not good, then probably in this patient IUI might not work. So the survival after 24 hours also should be good.
But Dr. Banker, do you agree to that survival? Because we are not doing it in our practice, but is it commonly practiced, not really much heard of in an IUI cycle? What about your view, Dr. Priya?
I think that 24-hour survival is more for a quality control check of your lab rather than deciding on the prognosis for the patient. So we normally do this only to check whether your lab conditions are okay and whether the sperms are surviving for 24 hours. Otherwise, from an IUI, even...
No, there was a paper, Manish, it was published, which looked at the 24-hour survival, and it said that if the 24-hour survival isn't good, then it's best not to do an IUI. I don't remember the name of the author, but there were two papers which were published on that, and they also looked at the survival.
So Dr. Priya, yeah.
I think in a case like this, probably IUI would be the simplest and the first step of treatment. So I would not waste time with any other further investigations and maybe start with the treatment straight away.
So Dr. Priya, when we are looking at this kind of a semen, what is the optimum post-wash semen concentration where you can counsel the patient? Suppose you've done the first IUI and you get a report. So what is a comfortable count and the motility, what you're looking at?
Shweta, in our unit, we routinely submit all abnormal semen analysis for a trial wash. And we don't only look at the post-wash concentration or the motility, but we look at an index called total motile fraction. So total motile fraction is the post-wash volume into concentration into progressive motility. So in my unit, the total motile fraction post-wash, that is the inseminated wash count, it ideally should be more than 5 million. But even if it's more than 1 million, we still take some patients for IUI.
Yes. Dr. Banker, what about you? Dr. Nagori, what would you do?
If it is the literature says that 0.8 to 5 million, anywhere between 0.8 to 5, there are a lot of papers. Some people say 1 million, some people say 2 million, some people say 5 million also. But by and large, more than 1 million, I would like to go for an IUI.
Yeah. So more than 1 million. And Dr. Banker, what about you?
I think as Dr. Nagorya said, there is no absolute cutoff which has been defined.
Yes.
And the reason behind this is that a lot depends on the wife's fertility as well. So if the couple is young, is not married for a longer duration of time, even at a 1 to 2 million post-wash count, you would still try with IUIs. But you have another couple who is 37, 38, married for 10 years. I mean, even at a 1 million post-wash, I would rather ask her to move into IVF.
Yes. So I have one question. Suppose on 2 consecutive IUI cycles, you had counseled the patient that we would do 3 IUIs, and in 2 consecutive IUI cycles, we see a post-wash semen analysis is 1 million. She's a young couple. Would you still advise her a 3rd IUI, or would you start counseling her for an IVF, because we are sitting in a center where we have both the facilities?
Yeah, I would certainly give them the option of an IVF. It is not that you will never do an IUI.
Yeah.
At least it would be the right time to at least introduce IVF into the paradigm to the patient.
And how many maximum cycles would you actually advise in your practice when we are looking at, say, between 1 million to 10 million total motile sperm concentration? Dr. Priya, what would your be maximum number? I just want a number and then we can move on.
My number for such a patient would be 3, but for those patients with sexual dysfunctions or maybe logistic issues, we can go up to 6.
And Dr. Nagori, what about you?
See, what I have observed in my patient, what I have analyzed, that when I get about 5 to 8 million count post-wash, then the pregnancy rates are excellent. But when the count starts decreasing less than 5 million, then the conception rate is definitely low.
Dr. Shweta, can I just come in?
Yeah, sure, Dr. Picky.
In our hospital, generally, we are not doing IUI if the total sperm count is less than 10 to 12 million, motility less than 30%, and viability less than 4, morphology normal.
So, Dr. Picky, do you refuse such cases?
These patients, we counsel them that the prognosis is not going to be good, because we need to have at least 5 million post-wash count to give a optimal response.
So do you check a post-wash count before you start, declining IUIs?
Actually, we try for the first time, but as you were saying, if we get a count less than 5 million, then we prognosticate them and offer them to go for IVF. Many of our patients can't afford, so we do continue.
So the unanimous agreement was that yes, we will offer IUI. Unanimous agreement was that yes, we can try up to 3 cycles for this patient. Some evidence which Dr. William Omelette and group said, they said the cutoff values were inseminating motile count if it was more than 1 million, or before you prepared the semen sample, if the morphology is more than 5%, the total motile sperm count is more than 15 million, and the total motility in a native sample is more than 30%, you expect better results, and this is how you can prognosticate the patient, though it has a better specificity. And this is a nice paper which said different cutoffs. And if you can see the red line where you had a 16, they had a 16.9% if the motile sperm count was between 9 to 9.9 million. So 1 million is like a cutoff where you can start doing an IUI. But if you have over 8 million count, then you will expect better results. And is there any last question for this case? Is there any role of double IUI? And if it is, you are advising, I just want from my panelists, one-liners, that if yes, then at what interval are you advising it?
In our practice, we looked at our retrospective data of more than 1,000 cases, and we found that actually in patients where we have done a double IUI, we got a 13% pregnancy rate compared to a 9% in single IUIs.
And at what interval did you do, Dr. Priya?
After trigger, 24 and 48 hours.
And Dr. Banker, if you are doing it at what interval?
I generally do a single IUI at around 38 hours. I have never done double IUI.
Dr. Nagori, what about you?
12 hours and 36 hours.
12 and 36. Dr. Picky?
When I do it only for male factor infertility, and 24 hours and 40 hours. 40 to 40.
40. And what about you, Dr. Madhuri?
Yeah, I basically do a scan after 24 hours. So if she's not ovulated, then I would do an IUI at 36 hours.
So these are the few advantages: more motile sperms for longer period of time. Then we have some evidence which started from Human Reproduction 2010. They said no difference in live birth rate. But then we have a couple of evidence which now says that there was a twofold increase in pregnancy after a cycle with double IUI as compared to single IUI. Again, we have another set of evidence which said double IUI done between 18 to 24 hours and 36 to 48 hours post injection of HCG, double pregnancy rates in IUI, which was significantly higher. So possibly we can think of a double IUI in male factor. And we just heard some evidence emerging in gonadotropin cycles, which Dr. Ghulam Bahadur said, but we need to look into more. Now, the second case, I would want Dr. Nagori, Dr. Leena, and Dr. Madhuri Patil to, majorly pitch into it. She's a 32-year-old lady, a case of secondary infertility of 2 years. She underwent a laparoscopy. She had a spontaneous abortion at 6 weeks, 3 years back. And early endometriotic spots were found, which were fulgurated. Otherwise, pelvis was clear. Hysteroscopy normal, no other comorbidity. Semen analysis as per WHO 2010 normal, AMH 2.2 nanograms. Now my question is to Dr. Leena, that what is your diagnosis and first line of treatment?
If you see on laparoscopy, even if endometriotic spots are present, I would like to label her as case of minimal endometriosis and go on that lines.
Right.
So if we label her as either minimal endometriosis or unexplained infertility, the treatment is on the same lines.
Right. So basically, if laparoscopy was not done, she would have been absolutely being treated as a case of unexplained, and now we have diagnosed, but more or less our treatment would kind of be same. What about you, Dr. Nagori? What do you agree on this?
Whether we fulgurate or we don't fulgurate, the pregnancy rates are the same. So I call it as an unexplained infertility.
Yes. Dr. Madhuri, what about you?
Basically, when we expand our investigations, then probably the incidence of unexplained infertility reduces. Yes. And there are certain conditions which basically we can label these patients as unexplained, and especially like mild endometriosis, where patients have subtle tubal abnormalities, or they have premature ovarian aging, or some immune reasons, as well as sperm dysfunction, wherein the count and the motility is normal, but the acrosome reaction may be affected, or basically the penetration into the lemma might be affected. So these cannot be diagnosed by just doing a semen analysis. So these are certain subtle abnormalities which could probably be diagnosed only if we expand our investigations. And these patients are usually labeled then as unexplained. But if it's mild endometriosis and unexplained, the treatment is almost not going to differ. But if it's going to be a subtle tubal abnormality or premature ovarian aging, because in the tubal abnormality, we know that the pregnancy rate can be affected, then probably we need to move early towards an IVF cycle. And even premature aging, because what happens is we know that the egg quality also can be affected.
So Dr. Leena, would you now advise this patient with good ovarian reserve, a decent years of infertility, not a very long, an IUI? If you are advising an IUI, what would you consider a natural cycle in this scenario, or some stimulation? And if you're thinking of stimulation, then what is your drug of choice?
First of all, I agree with Dr. Madhuri totally that there are subtle defects which is already discussed. So in such a case, IUI definitely gives a better result. So definitely, I would like to plan for IUI, not with natural cycle, but with ovarian stimulation. But maybe since I've seen the endometriotic spots are there, I would like to prefer letrozole in this case.
So what is your algorithm in unexplained infertilities or minimal endometriosis, which you have fulgurated in your center? So could you just elaborate that? How would you go about the first cycle letrozole? You would advise 3 cycles of IUI. You would advise an expectant management after that, or would you advise to go for IVF? So if you're advising IUI, what is your cutoff for the number of cycles in such case?
Management is a big no. See, the maximum chances of conception are in the initial 3 months.
Yeah.
With the case of endometriosis, it is proven that if you are giving superovulation with IUI, and in such a case, I would like to use letrozole with gonadotropins, mild ovarian stimulation protocol, along with IUI to enhance the pregnancy.
Okay. Dr. Nagori, what about you?
I always go for IUI. I will never go for natural cycle because the conception rate is only 2 to 8% with the natural cycle. And I will always go with the gonadotropin rather than the oral ovulagens because the fecundability also increases as well as the pregnancy rate is almost about 26 to 28% as compared to 10 to 12% with the oral ovulation.
So, Dr. Nagori, in your gonadotropin choice, what is the dose and what is the brand, and not the brand, but urinary or recombinant?
See, preferably I will always go for recombinant. The only reason is that it can be self-medication is possible with the recombinant. And second thing is the dose required is less as compared to urinary gonadotropin.
Yes.
If you see the bioactivity of the recombinant is exactly mimicking the periovulatory period of the FSH which is secreted at that time. While the urinary is prepared from the urine, which is having the least bioactivity from the menopausal urine.
So do you prefer then 75 unit in such patients as a starting dose?
I will normally I will prefer to this for an IUI. I will combine letrozole with recombinant FSH, and I will give letrozole for 3 to 7 days, and from 8th day onwards I would like to give the gonadotropin. So there will be more or less 1 or 2 follicles only. If I start with day 5 in some of the patient, I may get a multiple follicles. So it is better to combine with letrozole to have a less dosage of gonadotropin, less costly to the patient, and equivalent pregnancy rate.
Does any of the panelists differ in their stimulations, Dr. Madhuri, Dr. Banker?
I think there's no difference between recombinant and urinary. I mean, gonadotropin is what you're using. And when we're doing an IUI, we know that the pregnancy rate never exceeds 20%. And therefore, I mean, I don't think you should make a cycle expensive for the patient. And the dose basically will depend upon the AMH and the antral follicular count of the patient. If the patient is a normal responder, I can always start with 75. But if she is a patient of polycystic ovaries, I would usually start with 37.5.
Yeah, so we'll be coming to that case. So right now, yes, Dr. Nagori, what did you want to say?
Telling means I did not say that will improve your pregnancy rate. What I said that the dose required will be less. And then if you compare the cost will be not less the same.
The cost is not same. Definitely the cost of recombinant hormones is almost double or triple that of God.
Dr. Banker, do you want to say something different in this? So the panelists unanimously agree? Yes, sir.
I think it is not a question of different, but this controversy of whether to use urinary or to use recombinant is an eternal fight. The basic difference between the two products is that the recombinant is a far purer product. It is far more consistent than the urinary product. It is not that the urinary product is inferior, but since the consistency of that product is not as good as a recombinant product, you will always have instances where your patient do not respond as well as you want.
So sir, would you...
For a particular patient, it may not make a difference. But let's say over a period of 1 year, if you are continuously using recombinant versus continuous urinary, you will have superior results with recombinant. That goes without doubt.
So sir, is there anyone who wants to use clomiphene in such cases?
No.
Okay, so my panelists are a little bit more aggressive in their stimulations. Dr. Leena wanted to go with oral ovulation induction agents. I think Dr. Nagori also coupling it with some gonadotropin. Dr. Madhuri and Dr. Banker want to only give gonadotropin and unexplained. But the bottom line is that yes, we can comfortably give about 75 units of gonadotropin as the starting dose because they are normal responders and we should not confuse them with hyper responders. And this is just certain, evidence which we brought that IUI with ovarian stimulation versus expectant management, and expectant management brought in a very, very low pregnancy rate of 9% as compared to 31%. So the first line is that stimulate the patients. The next is natural cycle versus induced cycle. Again, 6% versus 18 to 19%. So whether you're using clomiphene, letrozole, gonadotropin, but stimulate your patients and aim at 2 follicles. Maybe with pure letrozole cycles at 2.5 milligram, you may not be able to achieve 2 follicles. So please look at your regimes, that which regimes can bring in about 2 follicular growth to make you jump the pregnancy rate. And then we have the fast trial, which said the conventional arm, clomiphene, 3 cycles, gonadotropin 3 cycles, followed by 6 cycles IVF, and the accelerated arm only after clomiphene switched to IVF, where the pregnancy rates in the first group were 8.5% versus 11% and 38.6% in the IVF. But then we have also groups which are stating and showing that the pregnancy rates in the gonadotropin cycles were higher. It depends upon what the dose you are using. This study was quoted earlier by Dr. Ghulam Bahadur, which said that letrozole, gonadotropin, and clomiphene in unexplained. Letrozole resulted in a significantly lower pregnancy rate of a significantly lower multiple gestation, but also a lower live birth rate when it was compared to gonadotropin, but it fared the same when it was compared to clomiphene. This is again just the data, Cochrane, which says stimulate the patient and then do an IUI. Possibly we all agree that 3 cycles, if IUIs are not working, you can suggest IVF to these patients. And then the last, which Dr. Abha also showed in the afternoon, that the recent data is that why give gonadotropins? Because the dose at which it will cause a multifollicular growth may be a dose which will be costing you more of multiple pregnancies. So time to ponder, but you have to juggle in your clinical practice where you have to optimize your stimulation, use your drugs carefully, and try to increase the pregnancy rate and try to see that which stimulations are making more than one follicle. That is ideally 2 follicle, but not more than that.
Shweta, it is important
Yes,
to highlight,
yes.
I think it is important to highlight that expectant management, only ovulation induction, and IUI without ovulation induction. These three are absolutely, I mean, low pregnancy rate treatments, and I think we should not offer either of these three.
Yes.
This is the bottom line.
Yes, I agree, sir.
Yeah, that is what I wanted to highlight. That a lot of studies, even after that Cochrane review 2015, have come up, which says that when you compare IUI versus IVF in unexplained infertility group,
yes,
the pregnancy rate with IUI is good and it is more cost effective.
Yes, absolutely. So we all agree unanimously.
In unexplained infertility.
Yeah, but I think, Shweta, we also need to look at the cost factor. And in India, I mean, many patients probably would not want to go directly for IVF because of the cost that is involved. So they would still prefer to do an IUI. So in that case, I think a gonadotropin IUI has a higher pregnancy rate rather than having a CC IUI.
So in my practice, most of my unexplained infertilities are on gonadotropins. And then I just wanted to bring in the evidence because they also are supporting clomiphene. But yes, we need to juggle. So what we need to see is the patient profile, the indication, the stimulation, how many follicles, pregnancy rate, and the cost, I think. And then we can decide that what works best for our patient. Moving on to, yes.
In our practice in Lady Harding, in most of the women who are ovulating, that is mild endometriosis or male factor, we generally combine oral ovulation with gonadotropin, like Dr. Leena was saying, because just oral will have a very low pregnancy rate. They are already ovulating. So we need to develop at least 2 follicles.
Yes, absolutely, I agree. So if your clomiphene is helping you with that or gonadotropin, and that is why I also resort to gonadotropin more often. This is a very short case. I'll quickly just discuss. Dr. Priya and Dr. Piki can discuss this case. She's 30-year-old, primary infertility of 2 years, recent laparoscopy, says right tube patent and left cornwall block. Hysteroscopic cannulation was attempted, but it failed. So we know that it is a true block. Normal cycles, normal semen analysis, good AMH, and no previous treatment history. So when you are dealing with a previous a unilateral tubal defect, Dr. Piki, I would like to ask you that what is the fertility option for this lady?
There are 3 options. We can tell her to go for expectant management, which we generally do not do because they have already been trying at home. Then we can go for ovulation induction with IUI, or if on laparoscopy I find that the distal tube is also damaged, the whole tube is damaged, the tubo-ovarian angle and the morphology is all damaged, there is evidence of tuberculosis, previous PID, previous surgery, and there are other factors, then we refer them, we tell them the prognosis and let them choose for an IUI or an IVF. But if there's no other problem, then we go for ovulation induction with IUI.
So in an isolated unilateral tubal defect, which is a Cornwall block, you would ask the patient to go for an IUI.
Yes.
Dr. Priya, what about you? So Dr.
Yeah.
Piki, we can just finish with you that suppose you're using an IUI cycle for her, what drugs would you use for her in this
Again, as
case?
she's already ovulating, I would like to start her on CC with gonadotrophin. So not Letrose, because Letrose will give one follicle. So CC with gonadotrophin would be my choice.
Okay. What about you, Dr. Priya?
I agree with madam. One dilemma which always the patients and some doctors have is that if there is a unilateral tubal block, the ovulation should always happen on the patent side. But we all know that ovulation happens in the pouch of Douglas. So any ovary can have the follicle and we'll still go ahead with the IUI. There is no role of cancelling. Number two, I somehow in my experience in patients who are ovulatory, clomiphene works really bad for IUI cycles because it causes bigger follicles, thinner endometrium compared to patients who are anovulatory. So my choice would be letrozole and gonadotrophins. If she's affording, maybe only a gonadotrophin cycle.
Now, I also wanted to ask that suppose if on the side of tubal block, the dominant follicle is forming, and on the other side also you see that a smaller athlete is there. So do you introduce an antagonist and keep giving gonadotropins so that the other side, which is the patent side, also, has a lead? Have you done that?
No, at least we don't, because we have seen many of our patients, they have contralateral ovulation and they conceive. But yes, we know that if she has just one follicle, not for the reason of tubal patency, but just because I would like to have 2 or 3 follicles in my IUI cycle to improve the success, I might give her an antagonist and wait.
So in this case where, the block tube started showing a dominant follicle, Dr. Picky, would you have proceeded for IUI where the right ovary was just not showing any dominant follicle, or do you still do an IUI?
Generally, we prognosticate the patient, tell her about the danger of ectopic, and if she agrees that she wants to continue, I will tell her to go for a natural contact. Generally, we don't do IUI.
And what about you, Dr. Priya?
Can I
No,
say
we go ahead. We go. There's
You
absolutely
go ahead because you prognosticate the patient for. What about Dr. Banker? What do you do?
Sweta, can I say something?
Yeah, Dr. Nagori, please say.
If we see the physiology of it, the ovary of Imbrieca is attached to the ovary. And
Yes.
when it contracts, the tube comes in contact with the ovary in a normal physiological way. So when the tube covers the ovary, it completely covers, the femoral end completely covers the ovary. And at that time, the ciliary movement of the columnar epithelium starts. It causes -1 millimeter of pressure. And that negative pressure sucks the ova in. So more or less, that is why in an IUI, we always see that the tube-ovarian relation has to be normal. If they are normal, then and then the chances of conceptions are very good. It does, ovulation can occur in the pouch of Douglas, and because of the movement of the femoral end, the ova may come in that. But in majority of the patients, that ova goes inside the tube, not like a roller ball, but it is the tube that takes an ova rather than the ova which goes inside the tube.
So I think you will also cancel that particular cycle. Only you will do it if the
I'll ask for a natural relation. I'll not
natural relation.
because
Okay.
once you do an IUI, it is your
So there
failure.
is there is really no as such data which says that to natural contact, yes, the data is there, 30% chance of conception, but to go ahead with IUI or not, it is not there. This is just a data suggesting that the clinical pregnancy rate with unilateral tubal defect was 26% versus 44% in unexplained group after 3 cycles of IUI. But proximal tubal defect had better prognosis than distal. So maybe in these particular cases, 3 cycles of IUI and then you can go to IVF. I will hand over to Dr. Neeti for the further cases.
Good afternoon, dear panelists. So we go on to the other cases, to other case scenarios. Case number 4 is to Dr. Nagori, Dr. Manish Bankar, and Dr. Leena, but I would like inputs from other esteemed panelists also. So this is a case of PCOS. Mrs. N, 30 years, female with primary infertility for last 3 years. She's a known case of PCOS with irregular cycles every 2 months. Her BMI is 27. Her AMH is 7.7 nanogram per ml. Thyroid prolactin is normal. HSG showed bilateral patent tubes and semen analysis is normal. She has taken clomiphene 100 milligram for 3 cycles in the past with documented ovulation. So basically, she is a case of clomiphene failure. So my question to Dr. Nagori is, sir, will you advise IUI in her, and which drug will you use next?
First of all, I will never use clomiphene citrate. That is not a drug of choice as far as the PCO is concerned. These are the cases where I would like to use the letrozole as a first line of treatment. And my normal practice is to combine letrozole with the gonadotropin and then to do an IUI, which has given me a very good pregnancy rate.
Okay, so you will combine letrozole with gonadotropin in this patient.
PCO patients, specifically for PCO.
Yes, this is specific to PCOS. Dr. Manish Pankar, what would be your choice of drug, sir, for clomiphene failure?
I think I agree that for a patient of this type, I would do a letrozole gonadotropin combination IUI. Generally, for PCO patient, I give letrozole for 5 days and give the gonadotropins on alternate days in the first cycle. If the patient does not respond, then I will stop the letrozole and use the gonadotropins in the standard chronic step-up protocol, start 75 international units daily, and then step up the dose if the patient is not responding well.
Okay. Dr. Leena, in your setup, it's a government setup, I know. What would be your next choice of drug in a case of clomiphene failure?
This particular case, definitely I would like to put the patient on letrozole, but I'll not add gonadotropins in the first go. She has prolonged irregular cycles. So maybe the follicle comes up late. I would like to monitor her till the later part of the cycle. And if the follicle comes later, then I'll go for IUI.
Okay, because the idea in clomiphene failure is to both, change the drug as well as to introduce IUI to make the chances of conception better. So there is a study which showed that in patients who fail to conceive with CC, gonadotropins have higher pregnancy rate for ovulation induction. However, pregnancy rates were high enough with letrozole also to justify its use in this population of patients. So either of these drugs can be used. When we use gonadotropins and IUI, as Dr. Banker was just saying, the recommended starting dose of gonadotropin is 37 to 50 IU per day. And we maintain the starting dose for 7 to 14 days, small FSH dose increments we do, and a very close monitoring. And this is how we proceed. But Dr. Nagori, because you were saying that you are more fond of letrozole, in case she had received letrozole in past instead of clomiphene, how you would have proceeded? You have given her gonadotropin straight away.
See, what I would like to do a baseline scan. If the enteral follicle counts are maximum, normally in a PCO patient, we always get AFC for 15 to 20, more than 20. So these are the cases where I will give letrozole and then I will start gonadotropin on from day 8 onwards. But if it is a poor responding PCO, then I would start also straight away with the gonadotropin.
Yeah, like she has ovulated in all the 3 cycles with letrozole, but she hasn't conceived. So you will still think of giving letrozole and gonadotropin, or you will switch on to?
Letrozole is not a cause for the failure of conception. You don't say that the letrozole is the cause that she has not conceived. And that's why I would like to continue letrozole with gonadotropin to have a better quality of a drug, to have a better vascularity of the follicle, and then to do an IUI to this patient.
Can I say her BMI is 30. So I think we have a point in reducing her weight by adding metformin may help, and lifestyle thing can reducing weight will also help.
It's not an obese PCO.
27.
30, acha. It's okay.
27. Definitely, letrozole failure is not well defined. The way the clomiphene failure is defined, so it is said that letrozole failure should be managed more aggressively. Whether there is a role of clomiphene, we don't know. Suppose there's a poor, a patient from a poor setup, Dr. Picky or Dr. Leena. Would you consider giving clomiphene, trying once with clomiphene if the letrozole, it does not happen with letrozole pregnancy?
I will think of adding metformin in such a case.
Yes.
Okay. You can think of adding metformin, or you can think of reducing weight, as you just said.
If you see, if the patient is ovulating either with clomiphene or with letrozole alone, adding metformin does not add any value. Basically, metformin is only for patients who are not ovulating then, and if you don't want to move to gonadotropins, then there is a role of adding metformin.
No, there was a recent review in BMJ which said that in patients also who are ovulating, if you add metformin, it has increased the pregnancy
Metformin plus letrose has a much better pregnancy rate as compared to letrose alone. And the next step would be gonadotropins if she doesn't respond to metformin and letrose.
2018 guidelines never recommend metformin as a drug to be used for ovulation induction.
Yes, sir, but there are few trials. Induction, it is basically along with the ovulation induction.
Adjuvant, not a
only
drug.
for ovulation induction. Initially, it was said that it should be used only in patients who had impaired glucose tolerance. If you see the 2018 guidelines, they say addition of metformin to the ovulation induction drugs does improve the outcome of your treatment.
Totally with the CC resistant cases, and now CC itself has got no role in PCO. So there is no point in adding metformin to improve the pregnancy rate.
Have a role. I mean, CC. I mean, there are patients who do not respond to letrozole, and where you use CC and they have responded and they have conceived also. It doesn't mean that they don't have a role.
I mean, BMI is on the higher side.
Yeah.
Ma'am, do you think of giving CC in such patients who have failed to conceive with letrozole?
Yes, I have given, and I have had patients who have conceived.
Okay. Now, the follow-up of this patient was that, she got stimulated outside with CC because she had failed to conceive with CC 100 for 5 days. This time, the clinician gave her recombinant FSH 75 unit after 5 days of CC. And when she came to us with a day to ultrasound, this was the picture. And we told her to get an E2 done, and this was the E2 level. So, Dr. Banker, what would be the next step for her in your practice?
So I think first thing is that this particular stimulation has been extremely poorly managed. I would have never given CC 100 with 75 units of rec FSH to this patient. Having said that, if the patient has already been put on those medication, ultrasound finding is sufficient enough. Actually, estradiol will not add value to your measurement. With 4 dominant follicles and 1 follicle of 14, I would not proceed with an IUI definitely. The risk of hyperstimulation may not be very high, but the risk of multiple pregnancy is significantly higher. So my choice in this scenario would be to cancel an IUI, because even for conversion into IVF, the follicles are not so great. So possibly for this particular patient, I would cancel the IUI.
Dr. Naguri, what is your cutoff, sir, for cancelling an IUI case? What is the number?
There are more than 4 follicles on both the sides. Then you must explain the patient. You should discuss, because you have got an option of GnRH agonist as a trigger that can be given to the patient. But this GnRH agonist trigger does not prevent the secondary OHSS. That should be explained to the patient. And chances of multiple pregnancy, even the higher order multiple pregnancies, are very common. So it is better to postpone this cycle.
So it is clear that we all agree that we will cancel this cycle. And at the same time, we do not think of converting her to IVF, isn't it? We don't think of converting her to IVF because her response is quite poor for that. So different criteria have been given for cycle cancellation. Some say more than 3 follicles, some say more than 4 follicles. We can make our own, practice points. As Dr. Naguri just said, that, if she insists on IUI, suppose this patient says, no, I have taken so many injections and I want IUI whatsoever, and I'm ready to take the risk of multiple pregnancy, will you consider GnRH agonist trigger? Dr. Naguri says that he will give it. Dr. Banker, do you give GnRH agonist trigger in such situations?
I would never give an agonist trigger in an IUI cycle because of 2 reasons. One, the whole mechanism by which an agonist trigger works is that it kills the corpus luteum. And if you look at the IVF pregnancy rates, the moment you give an agonist trigger, the fresh embryo transfer pregnancy rates drop drastically. If you want to salvage it, you need to give very extensive luteal support. So for a procedure like IUI, giving an agonist trigger and then extensive luteal phase support does not make sense. Secondly, by giving an agonist trigger, allowing her to become pregnant, we are putting her at risk of a higher order multiple, plus the risk of a late onset ovarian hyperstimulation. So keeping both this scenario, I would reserve the agonist trigger for an IVF cycle only, never for an IUI cycle.
Dr. Madhuri Patil, would you like to add something, ma'am?
No, I also don't give a GnRH agonist trigger in an IUI cycle. I will explain to the patient I would like to cancel, but there are some patients who say they don't mind taking the risk. In this case, I would give a HCG trigger and do an IUI. But
So
most
what
of the
dose
time
of
we
HCG
try
will you give? What
to-
dose of HCG will you give, ma'am?
I normally use 250 micrograms of recombinant HCG.
Yeah, I would like to differ here, Dr. Neeti, because in my practice, like if the patient is young, definitely we'll counsel her to postpone IUI. But if the same scenario, the patient is elderly, she wants to take a chance, then I would definitely, we use triptorelin 0.2 milligram with luteal phase support. We give Defaston 10 milligram BD in such patients and we proceed for IUI with GnRH agonist trigger. And we have got good results with that also.
Dr. Picky?
I agree with Dr. Leena. We also give GnRH agonist trigger and we follow up the cycle, give a luteal phase support with natural mechanized progestogen or Defaston.
Okay, so some panelists, they feel that GnRH agonist trigger is an option, but will GnRH agonist trigger prevent multiple births? It does not. Does it prevent late OHSs? It does not. So, you know, one option could also be to let them ovulate on their own and try naturally if they want to go ahead in this cycle, rather than doing a trigger and doing an IUI.
Late
For this also, you need to counsel the patient that there are chances.
On the contrary,
Multiple pregnancy. If they still want to continue, because they have taken drugs, so that could be one option. If they still,
on the contrary, Neeti, I feel that it's very important to tell them abstinence because
yeah, we do that. We do that, Dr. Priya. This is a patient who is insisting, you know, because she has taken drugs and she still wants to do something
Yeah,
about
I
it.
think the patient might insist on
For the late
something.
OHSS, because late OHSS is severe always, and it is always very difficult to treat the late OHSS. That's why this should be counseled to the patient very well, that you are putting yourself into the risk.
Danger.
And Niti, if the patient insists, it does not mean that we should do something which is of harm to the patient. Patients will always insist on things, but ultimately we have to put
Very
our
true,
foot down.
sir. And it is very important for the private practitioners to understand that, you know, we have to put our foot down at one point of time, that, you know, we are not going to help them more, you know, and putting them into danger. So we are going on to the next case now for Dr. Madhuri Patil and Dr. Priya Bhave. Mrs. K, 29 years old, lady, married for 3 years, willing to conceive. Her husband was diagnosed as HIV positive 1 year back during a routine checkup, while she is HIV negative. Her cycles are regular, AMH is good, tubes are patent, and male factors is normal. So this is basically a discordant HIV couple with the male partner being positive. So how will you counsel the couple, Dr. Madhuri, and regarding the options available to them and the risk associated? And what tests will you do before taking up this couple for further treatment?
Yeah, so basically we need to counsel that if they have a natural intercourse, there is some chance that the wife also can become positive, and it depends upon what is the status of the viral load. So if the viral load is less than 200, then the chances of transmission to the wife is less, and we can then counsel them. And if it's less than 50 and the patient is on highly active antiretroviral therapy, then they can also try for a spontaneous intercourse. I mean, they can try for intercourse and go for a spontaneous pregnancy. But if the viral load is more than 500, we have to tell them that they need to go for an IUI. And when you're doing an IUI, it is better that you do a density gradient plus a swim up, because this helps us in remove most of the viral load from the semen, because it's basically present more in the seminal plasma rather than on the sperms. And that's why doing the viral load is very important, because we need to see that the copies of the thing, it's less than 200 when you're doing an IUI itself. And if the patient doesn't want to go, the other option is we have to tell them the other option. So they can also go for a donor insemination or they can go for adoption. So we have to counsel them for everything, because the sperm count is normal and IUI would work in this patient.
Dr. Priya, would you like to add something to this?
I agree. I think initial counseling is very important because it comes as a shock. We do the viral markers prior to procedure and it comes positive. They will need a referral. He needs to be started on antiretroviral therapy. The wife needs to be tested and probably her test needs to be repeated. They need to have an implication counseling as to what parenting can be with a HIV positive parent. Although it's more of a chronic disease now, but I think rather than the treatment itself, this is the part which is much of a great importance to these couples. As a lab at present, we are not able to offer services to seropositive men for semen analysis. So we refer them to an institute which can do it. So we don't have personally any experience with IUI treatments for seropositive patients.
Yeah, and basically it is said that they have to be on the antiretroviral therapy for at least 6 months before their advised conception. And I mean, we have to have a separate lab if we have to treat patients who are HIV positive, because there's always a chance of contamination in patients who are normal, and therefore most of the clinics, if they have two, they have a separate lab for the HIV patients, then only it's best to treat them. Otherwise, we need to refer them to a place where they have both. I mean, they have labs for both HIV and non-HIV patients.
Dr. Banker, do you take patients of HIV positive patients in NOVA?
We do take, because I believe that the infectivity for HIV, hepatitis B and hepatitis C is almost the same. So if you're taking couples who are positive for hepatitis B and hepatitis C, we should take even HIV discordant couple. But we use universal precautions. We will never freeze their semen, and they would be processed last in the day. So we have a separate SOP on how to deal with this patient. But we do not treat if the wife is positive. This is only when the husband is positive.
Okay.
Dr. Banker, just wanted to know, if you're freezing the sample, are you sending it for the viral load testing before planning for IUI?
No, I said
they don't freeze.
Do not freeze the sample. That is what I said.
You just process. The washing is done, but do not freeze the sample. Dr. Nagori, do you have experience
Hello.
No, Dr.
I can't. Please tell me.
Okay, so we have this committee opinion which came from ASRM. There is no ethical reason to withhold fertility services in HIV positive couples. Current antiretroviral treatment effective in reducing viral load, and use of sperm preparation techniques highly effective in preventing seroconversion of HIV negative female and transmission to offspring. Now the options available are: one is natural unprotected timed intercourse, but it is not routinely recommended anymore. IUI with prepared semen sample, it is a safe and effective strategy when normal semen parameters are there. IVF with exceed other factors requiring IVF, or theoretically to further reduce the risk of transmission, this can also be offered. And donor insemination, as Dr. Patil just said, completely, if the couple is not ready to take a 0.1% risk of transmission also, then in that case they can be offered donor insemination. Refer to HIV specialist.
If ART is done, then ICSI is preferred than doing an IVF.
Yeah, definitely, ma'am. Should the husband, when the referral to HIV specialist is done to see that the patient, the husband is on antiretroviral therapy, he's on optimum regimen, and the female partner, does she need to take a pre-exposure prophylaxis in case of fertility treatment? So who are the optimal candidates for fertility treatment? High motivation of childbearing, as Dr. was just saying. Well-controlled HIV infection with stable CD4 count, undetectable viral serum and semen. This has to be ensured before we start treatment, and antiretroviral adherence of more than 90%. But after all this, also a written informed consent must be taken before undertaking any treatment in such patients. So, Dr. Banker, how will the semen preparation be done in your lab for such couple?
Gradient method.
Okay. Dr. Priya, would you like to add something?
Dr. Priya had to leave.
Okay.
Basically, I do a double. I mean, we do a density gradient, and after that we do.
Yeah. So routine recommendation is the sperms are isolated by sequential density gradient and then swim up, and then tested by PCR assays for presence of viral RNA. Using this method, less than 1% of the samples will test positive. So that is how to go about it. Now, case number 6 is to Dr. Leena and Dr. Piki. This is a 39-year-old lady. She's married for 6 months only, and she's anxious to conceive. She knows that she's older in the reproductive life. Menstrual cycles 2 to 3 days by 25 days. Her AMH is 0.7 nanogram per ml. Her bilateral tubes are patent, and analysis is within normal limit. Now, if this patient comes to your OPD, Dr. Piki, what will be the options which you will give to her, what will be your advice to her? Expectant, that she should try more, or ovarian stimulation with IUI or IVF?
Since she is already a 39-year-old with poor ovarian reserve 0.7 by both Polagna and Pozidine, she is group 4. So I will not tell her to go for expectant management. She has to be told about benefits, the success rate of OS with IUI and IVF. And in our setup, we don't have IVF. So I will like to go for ovarian stimulation with IUI.
Dr. Lida?
Since she's married for 6 months, I'll do ultrasound for antral follicle count. If it is less than 4, I would prefer to do 1 cycle of gonadotropins with IUI in such a case before we counsel her further regarding IVF or need for IVF OD in such a case.
Dr. Madhuri, how would you go about it, ma'am?
I think we need to counsel her, and we need to tell her that because she's 39 years and moreover her AMH is 0.7. So if it is 0.7, it's no use wasting time in doing an IUI, and it's best to counsel her to go for an IVF, because it has been said that the success rate with IVF is much better in patients. And this patient basically belongs to group 4 of the Poseidon criteria, wherein she is more than 37 years and her ovarian reserve is less. So whatever you do is really not going to help you in getting more number of follicles, because the ovarian reserve is less. So increasing your dose or adding AMH is not going to help. So whatever her ovarian reserve is, she would have best chances if you do an IVF at this point of time.
Okay. Dr. Nagori, sir, what would you do for this patient, advanced age group?
I'm totally against it, because AMH 0.7 doesn't mean that IVF. I've got my fellow is going to publish a paper in next month only that we have 32 pregnancies with AMH between 0.3 and 0.9. So we have 32 pregnancies, and she will be publishing within 1 or 2 months, and that is with an IUI. So I will always give a chance of 1 or 2 cycles of an IUI. If you even see the literature below the 40 years of age, then you must give a chance for 2 cycles, 1 to 2 cycles of an IUI. If the patient does not succeed, if you don't succeed, then you go for an IVF. And IUI only with gonadotropin, with good ultrasound monitoring, then the IUI should be done. Simple IUI with oral ovulagens and just by 2D ultrasound, I will not prefer it. I will always go for color Doppler, and then I will do an IUI to this patient.
Dr. Banker?
Preferred option is IVF because the patient is 39 and a half. The only thing in favor of her is that she has been married only for a period of 6 months. So if she does not agree for IVF, maybe 1 at the most 2 cycles of IUI, and that too with gonadotropins alone.
Okay, sir. So our panelists are quite divided on their opinion about this patient who is 39-year-old, married for 6 months.
One more, Niti, I would just like to say is, because you've not mentioned the antral follicular count, many a times if the AMS is not done by the 2nd or 3rd generation assays, and it is done in a lab where it is using still the 1st generation, then this AMH may not be the right value. So basically, your antral follicular count is also very important. So along with that, many a times we see that the antral follicular is good and yet your AMH is low. In this cases, you can always give gonadotropins and try, because we really don't know the method of assay for the AMH. So if the method for assay of AMH is not right, then your values may differ, and probably you might overtreat the patient by doing an IVF for the first time.
See, when the antral
She's
follicle
39-year-old, ma'am. She's 39-year-old. And if the AFC is good, as you are saying, suppose the AFC is good, doesn't she have a better chance in IVF? Her time to conception.
If she has better chance, then we can probably just try 1 cycle of IUI, so we know how she responds.
Yeah.
So when you're doing an IVF, then your starting dose can be modulated according to that, in case the antral follicular is good. So I will not try for 3-4 cycles. I will try for 1 cycle, because that will tell us how her response is. So this will help us in choosing the starting dose of the gonadotropins for our IVF cycle, which will optimize the outcome of that IVF cycle.
So this was 4T trial, which was the sequel of the fast track. And this trial basically took patients who had 6 or more months of unexplained infertility, similar to our patient. And female partner is aged 38 to 42 years. And what they found was that the cumulative pregnancy rate per couple after the first 2 cycles of CC-IUI, FSH-IUI, or immediate IVF were 21.6%, 17.3%, and 49% respectively. So they said that after that, definitely, according to them, they said that IVF, going for immediate IVF, seems to be giving superior pregnancy rate with fewer treatment cycles. So the conclusion was that for couples at the end of the reproductive life with reasonable chance of success, immediate IVF is most successful. For those who don't want IVF straight away, this 40 trial says it supports that CC-IUI rather than FSH-IUI. It gives comparable success rate, but we can decide in our practice. However, couple who will initiate treatment with CC-IUI, they will finally conceive later by IVF only. So they will definitely require more treatment cycles to conceive at the end. So that was the conclusion. So what happened was that this couple decided to, because she was very anxious, she decided to go for IVF directly. She was taken up for antagonist cycle and started on day 2 with 300 units of FSH. And this was her ultrasound after 5 days of stimulation. She has, this is the ultrasound. Will you continue IVF cycle or consider converting her to IUI now? Dr. Patil.
Yeah, basically, it depends upon your day 2 scan. And therefore, these days, they say, because one of the disadvantages of using an antagonist cycle is asynchronous growth of the follicles. And this is basically because in these patients, usually the FSH is high. And when the intermenstrual FSH is high, you usually have one follicle which is larger because it starts growing and the other follicles are smaller. So I would just ignore that 16 millimeters follicle and I will continue with the treatment. We would always do an IVF because that is why many a times now there are many papers which are coming. These patients, the poor responders, have a better synchronicity of follicles when you're using a long GnRH agonist protocol, and because this will prevent the intermenstrual rise in the FSH levels. And it has been said that the number of mature follicles which are obtained when you use a long GnRH agonist protocol as against agonist protocol is a little higher, though the clinical pregnancy rates and the live birth rates are similar with both antagonist and the long agonist protocol. And the study by Sunkara et al. Said that basically where they compared all the 3 and they said that you should not use a short agonist protocol because they found that the clinical pregnancy rates are much less when you are using a short. So you can use either a long agonist or an antagonist, but if you have had an asynchronous growth like this, it is better to go for a long agonist protocol.
And ma'am, if we extrapolate it, suppose we go for a long protocol also, and because she has a poor reserve, she just makes 2 follicles. You have decided for IVF, she has decided for IVF, but she basically has only 2 dominant follicles at the end of the day.
Yeah, so we cannot increase the number of follicles. So even if she has 2, you have to go ahead with your IVF because that's, again, it's not only therapeutic, but it's also diagnostic because it's going to tell us about the quality of the oocytes, because many a times we know that with aging, even the quality of the oocytes may reduce. It's not only the quantity, because we know that this happens. So it's both diagnostic, and in this patient, probably if you want, we can do a double stimulation, or we can also pool the embryos or the oocytes and then subsequently do a transfer.
Dr. Banker, do you differ in opinion?
Can I tell you something? Can I tell you?
Yes, sir. Yes, sir.
See, it is very surprising that when we are using an oral ovulogenic and gonadotropin, we consider about the cost in an IUI cycle. And when you want to do an IVF, you never consider the cost of that patient. Why not to go for an IUI for this patient? Because there are only one follicle what you are getting of 16, and C is only 6 months married life. The tubes are open, so the same chance of pregnancy with an IUI and with an IVF in one cycle will be the same in this group of patients.
This 16 millimeters follicle is on day 5 of the cycle.
I'll wait for still 1 or 2 days for stimulation, and then I will get a follicle of 18.
Yeah, and then she's going to ovulate on day 7 or 8 or 9.
And then we can monitor that other follicle also, and we can advise the natural contact just to increase the pregnancy rate.
We can, Banker, what would you do in this situation, Dr. Banker?
I think what I would do essentially will depend on what you have counseled the patient to at the beginning of the cycle. See, this is not a patient belonging to Poseidon group 2, where there is an issue of poor response. She's basically a Poseidon 4. So we would have known from the beginning, looking at her antral follicles, that you are not expecting more than 2, 3, or 4 follicles at the most. Second, I would always like to synchronize by giving luteal phase estradiol so that we do not have this kind of asynchrony in the follicles. And thirdly, I would have always have added HMG inner stimulation. Pure FSH stimulation in this category may not have worked. Having said that, if the patient has had only one follicle, where there were a reasonable number of antral follicles, I will cancel the IVF at this stage, maybe allow her to conceive naturally or do an IUI, but give her a proper stimulation, having HMG, proper synchrony in a subsequent cycle if this fails.
So in the nutshell, when we are dealing with women with advanced reproductive age, we have to be more aggressive in our management. We can give them 1 or 2 cycles of IUI if at all, and then we should think of moving ahead to IVF. That was the gist of this case. Thank you so much, our esteemed panelists. We really gained from your experience and knowledge. Thank you so much.
Thank you very much. It was a great discussion, and I think we came to some consensus.
On behalf of all the panelists, I would really like to thank Dr. Shweta and Dr. Neeti for putting up such a wonderful panel with such important clinical cases.
Priya, you are still there. Thank you,
Dr.
Dr.
Priya must have finished her case and come back.
Thank you so much for joining.
Dr. Neeti, can we move on?
Yeah. So
thank you very much. Yeah.
Thank you.
Thank you very much.
So before we start the next session, I just want to, extend an invitation to the 16th annual Fertivision, which is going to be a virtual conference of a first virtual global congress of Indian Fertility Society, which is planned for 4th through 6th December. And this conference has just been declared free, complimentary for all the IFS members. They have gathered a galaxy of international and national speakers. So I would invite everyone to join this.
And everyone should see the topics. They are very, very interesting and very good workshops too.
Okay, so we move on to the session 4 now. And for this, I invite the chairperson, Dr. Neeru Thakral, who is the director, Morpheus Thakral International IVF Center in Thakral Hospital, Gurgaon. And she's also the secretary of IFS Haryana chapter. Dr. Mamta Dagar, who is consultant and associate professor, DRIPMA. And she is also the secretary of AOGD. Dr. Rupali Bassi, who is senior consultant, IVF and laparoscopy, Indraprastha Apollo Hospital. Over to the chairperson now.
Thank you very much. Thanks, Dr. Neeti. Now it's my great pleasure to invite Dr. Gaurav Majumdar. Dr. Gaurav Majumdar, we all know, is the chief embryologist and lab director of Sir Gangaram Hospital, New Delhi. He is.
And Gaurav had asked me that he will have 2 minutes more for the presentation. So he will.
Sure.
He has many, many things to share with us.
Okay. Gaurav, can you start sharing your screen?
Yeah. Okay, thank you very much for this invitation to this workshop. I'd like to begin by congratulating the AOGD organizing committee and Dr. Shweta Mittal and Dr. Neeti Tiwari for a stellar workshop up till now. So I have been asked to highlight the role of the andrology lab in optimizing IUI outcomes. So I'll try to do that in the next 15 to 20 minutes. And I've been asked to show a video showing the semen preparation technique. So I'll elaborate on that during this presentation. So, okay. So I will be speaking of intrauterine insemination, which is basically deposition of a bolus of highly concentrated functional sperm, free of seminal plasma and other cellular debris, directly into the uterus. So this is where the andrology lab comes into play, where this bolus of functional sperm will be prepared. So when we're talking of the IUI laboratory, there are three aspects that the general gynecologist who's listening in, they need to be aware of. First, that in order to, the personnel who will be manning IUI laboratory, as per ICMR guidelines, just a trained technician for semen preparation will suffice. However, such a person should be proficient in performing semen analysis according to the WHO 2010 guidelines, as well as cryopreservation of semen. They should have proficiency in semen preparation techniques. They also must be able to ensure functioning of all necessary equipment, as well as should be involved in record keeping and maintenance of all the paperwork that goes along with IUI procedure. Now, as far as infrastructure is required, it is a basic requirement where adjacent to the or in the vicinity of setup, there is a consultation room that is desired. The IUI laboratory requires a certain amount of equipment that we will list in the coming slides. Also need storage space for stocking consumables. Then a fridge is required for storing culture media at 4 degrees Celsius, and provisions for printing and record keeping are required. What is essential in addition to the laboratory or the space where IUI sperm preparation will be carried out is an adjacent semen collection room, preferably with an attached toilet and with audiovisual aid, as well as soundproofing. So this is something which is very, very essential and an integral part of a IUI laboratory. Now, when we speak about equipment, there are certain equipment which are essential, and there are some which are desirable but not essential. So amongst the essential equipment, there is the compound microscope, the sperm counting chamber. So here you can see that a proper sperm counting chamber should be used in order to make assessments about the count and the motility of sperm. And macular chamber is what has been recommended by the WHO 2010 guidelines. However, it is an expensive device. So the indigenous version of the same is also available in the city by the name of, by various names. I think one of them is called CryoCell. So this is a necessity. Please do not count sperm on plain glass slides with cover slips. And like I said, normal binocular compound microscope with phase contrast is what is required. In addition, you need a centrifuge with swing out rotors, preferably with a digital timer, and speeds attainable up to 3000 RPM. As far as a heating device is concerned, what you need is a dry incubator or just a test tube warmer, because all you need, these are for warming up the wash buffer up to physiological temperature. Now, the question about whether a CO2 incubator is required or is it necessary as a part of our IUI setup? Well, the answer is that it's optional, it's desirable, but it's not essential, because the moment you start using a CO2 incubator, you will need wash media, which is bicarbonate buffered. And this whole proposition becomes expensive and it requires pre-calibration. So this is to be used only in case if it is available. Otherwise, a normal heating device like a dry incubator would suffice. Now, about a laminar airflow hood, again, this is optional. It is not mandatory to perform semen preparations within a laminar airflow hood. So this just provides a vertical airflow which protects the operator and creates an area free of particulate matter. So it defines good laboratory practices, but it is not essential at the end of the day because we are only handling semen. So this is in a nutshell the basic equipment which is required in an IUI laboratory. Now, having gone past the basic requirements, now let us see how we can, what role does the andrology lab have to play in as far as optimizing IUI success rates. So if I broadly divide the IUI procedure, so there is a diagnosis and an indication part to the IUI, and then there is a cycle preparation, which is controlled by the clinical side, whereas the scope of this lecture will be limited to the technical aspects of IUI, which are present in the laboratory. So as you have heard since morning, there are a lot of clinical factors which contribute to the success of an IUI program. However, we are going to look at, so I tried to enumerate the laboratory factors which could play an important role in determining the success. So we're going to talk about the ejaculatory abstinence, then about the IUI devices, primarily the culture medium as well as disposables which are used, then the method of semen preparation itself, and finally going to speak a little bit about the time from semen collection till insemination. So the time period is quite vital. So I'd like to begin with ejaculatory abstinence, and we've heard about this by Dr. Bahadur in the earlier sessions. So I'll just be reiterating what he's already stated, and he's published extensively on this. So as per WHO 2010 guidelines, the ejaculatory abstinence, it has a very wide range of 2 to 7 days. However, as Dr. Bahadur has demonstrated, that if the initial sample is less than 5 million per ml, then a second sample collected within 40 minutes after the first results in significantly higher motility. And ejaculatory abstinence is inversely associated with exposure time of sperm to ROS, especially in infertile men. So this is the rationale behind trying to take a second sample. And there have been studies which have now unequivocally demonstrated a negative impact of longer EA on pregnancy rates. And this particular study found the highest pregnancy rates with abstinence of up to 2 days. And as Dr. Bahadur also published, that in cases of oligozoospermia, the aggregation of consecutive ejaculates resulted in a significantly higher pregnancy rate. So as per this very good meta-analysis, which was published in 2017 by a group of Dutch authors, they've put in, they advise to change the WHO recommendation into a ejaculatory abstinence period of a maximum of 3 days, which will help take care of all the IUI samples. Now, going back to the list, now we're going to talk about culture media and disposables. So as far as the discontinuous density gradient is concerned, what we need are colloidal silica suspensions in order to make 2 gradient solutions, which will constitute the double density gradient, 80% and 40%. And this density separation is highly effective in separation of normal sperm from lymphocytes and epithelial cells, and abnormal, immature, and senescent sperm, cell debris, and seminal plasma. Now, followed by the following, we need a wash media. And it's preferable to have the wash media as Hippe's buffered. And this is used for washing after density gradient separation. and it is able to maintain the pH in the physiological range, and it does not require any CO2 equilibration. And we do not now any longer prefer media with phenol red. However, in case one is using a CO2 incubator, then you need to make sure that the wash media is bicarbonate buffered, and it will need prior equilibration with CO2 before it is used, and which will just make the setup quite expensive. So actually this is not meant for IUI laboratory. Now, as far as the consumables are concerned, you need to invest in good quality consumables, whether it's the 15 ml conical test tubes or wide mouth semen containers, or the syringe and the catheter or pasture pipettes, which are used for semen preparation. Now, what is critical here is the cytotoxicity of these IUI devices. So we generally try to think of cytotoxicity or embryotoxicity only when we're thinking of IVF. However, cytotoxicity of any contact material plays a very, very critical role in IUI. And this kind of toxicity can be caused by so many things, like something like the composition of the materials, or the production processes, or the handling and packaging, or the sterilization. So, for example, the authors here, they demonstrated that with the help of human sperm survival assay, one kind of pasture pipettes, they resulted in delayed toxicity, and had a negative outcome on the motility, and so did the inside of the lid of a certain kind of semen collection container. So which had an immediate manifestation of and a negative impact on sperm motility. So this is how critical contact devices can be, including the culture media. So therefore, following good laboratory practices, it is very important to use only sterile, individually packed, non-toxic and good quality consumables. And it is most desirable to be able to perform sperm survival tests in every single batch of either the conical test tubes or the catheters or the pasture pipettes which are being used for sperm preparation. Because you cannot imagine the kind of toxicity, if any, that can affect the sperm parameters. And so similarly, pack sizes should be chosen depending on the workload to minimize the extended use of media after initial opening. And one should try to prevent repeated warming and cooling of culture media, right, for IUI sperm preparation. Now we will look at the method of semen preparation. And so the ideal method must be easy to perform, and it should be quick. So quick, I have highlighted, should not take too much time. Then it should help us isolate maximum motile sperm. So we will get to that in the coming slides. And obviously we want to eliminate all non-motile spermatozoa, dead spermatozoa. We want to eliminate all the toxic and bioactive substances. And in doing so, we do not want to generate reactive oxygen species. So all of these features are what define an ideal sperm preparation method. So there are two methods which are predominantly used. And the first one is a density gradient separation. And so let us just look at a video which will show you the whole method in detail. So these are the large mouth containers that we use for semen collection. And we have aliquoted the density gradient media. So this is the 80% and the 40% adequate volumes which have been warmed up to 37 degrees. Now, before we start preparing semen, it is very important to check the semen count and record the parameters, the pre-wash parameters, with the help of a sperm counting chamber. So this is the indigenous version, but the grid is same as Mackler. So as you can see, there are all kinds of progressive as well as non-progressive and dead and clumps of cells and sperm. So now we are using a good quality individually packed pasture pipette, and we are removing 1 ml of 80% gradient solution and placing it at the bottom of a 15 ml conical tube. So 1 ml of 80% goes at the bottom. And then now we need to layer another 1 ml of 40% gradient very carefully over the 80% layer, making sure that the interface between the two solutions is intact. That is where the dead sperm will get caught. And now we are adding the neat semen above this 2 ml gradient of 80-40. So this is again, here you can see again a very clear interface between the semen and 40%. So now this whole gradient needs to be centrifuged for 10 minutes at 1500 RPM. So this is post centrifugation. You can see it's all become hazy. So we remove the semen, the topmost layer, and then the 40% gradient, which is now all murky as it contains all the dead sperm and the debris, leaving behind the bottom 80% solution with the pellet right at the bottom. Now we need to wash post this density gradient separation. So we have to add 3 ml of wash media, which is HEPIS buffered, to this 80% containing the pellet, and spin again for 7 to 8 minutes. So this is what the final pellet will look like at the bottom of the 80% now of the wash media. And we concentrate the inseminate to about 0.4 ml and check again under the microscope. So as you can see now, we have attained a very clean bolus of motile sperm. So let's move on to the next method, which is also a very popular method. And this is known as swim up method, which is based on the active migration of the motile spermatozoa from the pellet into an overlaying medium. So here the only problem is that the ejaculate, in order to make a pellet, the ejaculate is mixed with medium and then centrifuge. So this may lead to production of a lot of reactive oxygen species. So hence an alternate way of performing swim up was suggested, which is known as direct swim up. And this doesn't require any centrifugation, and sperm is made to swim up from neat semen into a overlaying sperm wash media. And once that happens, then once all the viable spermatozoa has been separated, then it is subjected to centrifugation. So this limits the production of ROS. Now, however, it has now a consensus that the recovery rates are much lower with the swim up technique as compared to the density gradient. And as you could see, that it is only suitable in cases of normozoospermia. And there have been publications which have found that surprisingly, swim up technique leads it, the fraction which is obtained is actually comparable or lower motility and lower percentage of normal spermatozoa. And however, a good RCT was performed in 2014 and published, which finally put a rest to all the speculation on the conflicting reports before that, that with the use of density gradient centrifugation, a significantly higher pregnancy rate, both per cycle and per couple, was obtained as compared to swim up technique in couples with unexplained infertility. So to put this in perspective and a nutshell, with swim up, we get a lower recovery, perhaps a higher quality of sperm because we use swim up for preparing sperm for IVF. But our objective here to is to obtain as many sperm as possible, the highest possible yield, which is only possible with density gradient. Then also I'd like to add that in cases of highly viscous semen samples, double density gradient is, again, it works very well. And one can just break the viscosity by passing the semen through a 2 ml syringe and needle and then proceed. However, use of single density gradients is not recommended. They are not as efficient as double density gradients. And double density gradients also are suitable for very low sperm counts or very small volumes of semen also. Just one needs to adjust the length of the gradient these are known as mini gradients, where you can halve the volume of each gradient solution. Now, going back to the last point now is the time intervals. And when I talk about time intervals, there are 2 or 3 different types of time intervals that need to be kept in mind. So this was a very good paper which was published in 2014, where Falk et al. They showed that the time interval, so 40 to 80 minutes was the time interval from the end of sperm preparation to IUI that was associated with the highest pregnancy rate. So they according to them, this was the most vital time interval. And then recently, a couple of years back, there was another very exhaustive paper which demonstrated that there are different time intervals which have an impact on IUI success rates. And the first being the interval between semen collection and semen washing, where the optimal time was found to be less than 40 minutes. And then there was one from semen washing to IUI, which was 60 minutes or less, as proposed in the earlier publication. And so the cumulative time between semen collection and IUI, the best pregnancy rates were found when this was 90 minutes or lower. So speaking in a general sense, since there are a lot of papers with different times which are there in the literature, it is preferable to avoid long time intervals. And especially they found that having a time interval of more than 60 minutes between semen collection and semen preparation was quite detrimental to the results. So as far as the role of the IUI laboratory is concerned, it all revolves around quality control. And so I'd just like to wrap up by saying that the temperature of the fridge where the culture media is being stored, or the dry incubator where the media and the samples are being brought to physiological temperature, they should be calibrated routinely in an IUI lab. Then the centrifuge should be calibrated. Then in case it is possible to perform sperm survival tests to check the cytotoxicity of consumables or IUI catheters and culture media, this will make a huge difference in the outcomes. And you need to follow the good laboratory practices of maintaining your microscope and using proper semen counting chambers. And then hopefully we will have done enough to optimize the IUI laboratory, which is an important part of the whole scheme of IUI. Thank you very much for your attention.
Thank you very much. Thanks, Dr. Gaurav, for the brilliant talk and nice elaborating video. It's always pleasure to listen to you. So you have very nicely shown both the method, double density as well as swimmer, and highlighting even a smaller point and very good take-home point that abstinence up to 3 days is good enough before IUI. Time interval is very, very important. 90 minutes is the maximum time between semen collection and IUI. And double density is the method of choice, especially in patients where it is a highly viscous sample and yield is very good in the double density. Thank you very much.
Yeah,
Thanks.
it was a very, very crystal clear presentation, Gaurav.
Thank you.
I was
Always
actually
pleasure.
feeling as if I'm sitting in the lab when the semen preparation was going on.
Thank you. Are we
Dr.
doing the
Rupali?
questions at the end of the session?
Yeah.
Dr. Rupali?
Yeah. I now call upon the next speaker, Dr. Ruma Sathwik. She's a senior consultant in the Department of Reproductive Medicine at the Sir Gangaram Hospital. So,
Ruma, unmute yourself.
no, we can't hear you still.
Ruma, unmute. Yeah.
Can you hear me now?
Yes, yes.
Just give me a second while I try and share my screen. Can you see it?
Yes, it's seen.
Okay.
Let's make it full screen.
I'll just do that. So thank you, Dr. Rupali, for that introduction. My talk is basically focused on demonstrating the procedure to you and talking about what constitutes difficulties during IUI and how to overcome them. And while some of the methods used here might or might not be standard, because I could not find too much in literature that could define what is standard practice, I'll basically be talking about what is done at the Center of IVF in Gangaram Hospital, which is pretty much emulated, or I see this being done elsewhere as well. So what is a difficult IUI? So basically, we are talking about difficulties during IUI that may arise because of positioning the patient or in visualization of cervix or during cervical cannulation. And any of these leading to excessive patient discomfort or inability to perform the procedure itself, this would constitute a difficult IUI. So patient position, usually what it is done in is, we know it is dorsal recumbent, and this is a good enough position. But sometimes we may need to extend her thighs a little more, like flex and abduct the thighs a little more, in which case you might need to put her in the lithotomy position. So some very experienced consultants seem to use the dorsal recumbent, and some others will use the lithotomy position. You need to have a good IUI table, which will allow both these positions, so which has a cut and it can be broken down, so in order to allow both the positions that were mentioned. Now, a basic IUI trolley consists of, you can see here, it will have a Casco speculum. It will have the sponge holder, sponges itself, and what you see on the right, sim speculum, and these are only needed for difficult IUIs. Now here I've opened the IUI cannula, which comes along with the syringe, and you can see that this has been threaded into the hub of the IUI cannula. And this is the conical tube in which the semen is handed over to us. You identify the patient name properly. And once you have identified, loudly say it to the patient. You may need to show the label to the patient as well to be doubly sure that this is going in the right patient. And this demonstrates the procedure of filling up the cannula. You can see that the plunger is way at the bottom, and from where it pulls up the semen. And you can see there's an air column being lifted, which is equivalent to the dead space of the cannula, which is about 0.2 ml. And here we wait and now prep the patient up. So just a word about the cannula here. What you see in this picture is it's a straight cannula. It's about 11 centimeters, and it has got a hub or a cap which allows the cervix to be sealed properly. And this is then threaded into the insulin syringe, which has a volume of about 1 ml. Now, it's not a very difficult cannula to find. It's very commonly available. The cost is not much. It's about 100 to 150 rupees. It comes in variations, and one variation would be in the length. It has a firm tip, and it's not a floppy tip. So when it is lifted up, you wouldn't see it flopping like the embryo transfer inner catheter. And this is proven, as you will see in this talk later on, why you don't need soft catheters particularly for IUI. So here, this is the basic procedure. I like to say that all of this has been taken with consent of the patient and her husband. So after having positioned the patient and draped her, we are going to put in the Casco speculum in order to visualize the cervix. The cervical visualization is one key step here. And if you cannot, for instance, now this is not fully loading. So the cervix has to be visualized properly. You can see it has to be in this position for you to be able to do your IUI without any difficulty. And once you see this position is important in order to be able to do a IUI properly. Sometimes the cervix you'd see is too retroverted, or it's too pointing downwards, or it's pointing upwards, in which case it may not be able to cannulate the cervix properly. So a gentle dabbing of the cervix, and this is with saline swabs that we had initially taken. And this would then be followed by an IUI procedure per se. So I think my thing has not really been loading well enough, but we'll try and move on to the next slide. So here, sometimes what you will encounter is, so that was the basic procedure, is that you'll not be able to get this view of the cervix. And some of the reasons are that the woman is disabled. Maybe she's had a hip joint fracture, of maybe she cannot lift her abduct or flex her thighs enough. There could be vulvar lesions, any one of these, which prevent an insertion of the speculum itself, or she's too obese, or the vagina is too deep, or it's too lax, any of these which prevent a full visualization of the cervix. And lastly, and this is something that we see more and more in women who've had cesareans in the past, where and this is a picture here, you see that the anterior wall is stuck to the anterior uterine wall is stuck to the anterior abdominal wall, so that it pulls up the uterus to a point where the cervix is so pulled up that it is very difficult to visualize it vaginally. So what exactly do you do when there is difficult visualization? And you'll see how extended lithotomy, where the standard lithotomy is flexing the thighs to 90 degrees, but here you want to flex it to much more, so that the angle between the abdomen and the thighs is lowered to a much more acute angle. Similarly, the knees are flexed much more in order for the uterocervical angle to be tilted backwards. Secondly, you may have to now change your speculum from Casco's to Sims and Valsalem to visualize and pull down the cervix with the Valsalem. And third, sometimes when none of this works, sometimes you may need to use general anesthesia, and this is especially true in women who might have vaginismus, who might have some vulvar lesions that prevent insertion or make the insertion of the speculum very painful. So the second problem is, apart from visualization, is cannulation. So although you have been able to properly position your speculum and you're able to visualize the cervix, what you may not be able to do is cannulate. So all the uteruses and cervices are not as straight as you see in picture 1. There is likely to be a bend, and about 1 out of 5 IUIs that you do, based on several presentations and based on our own experience, you might experience difficulty in putting it straight in. So what are the other causes? Apart from this angulation, there could be cervical crypts or polyps, which again, when you're trying to thread your cannula in, it goes and hits the stalk of the polyp and the wall of the cervix. That's where it just goes and hits. So basically you need to try and some more trial and error in order to pull back, go in different directions in order to negotiate that. There could be a false passage that you see in picture 3, and so that you're constantly going in the false passage, and which means, and how do you recognize it? As you go in, you feel that you can go in, but beyond a point, there's great resistance, and sometimes your catheter tip bends. So when you're trying to push in the semen, it doesn't go in. In fact, there's so much pressure, you don't see the column moving forward. So you know that the cannula has, the catheter tip has bent from the front. And lastly, and the fourth picture is a rare complication. You don't see it as often, but sometimes there might be cervical stenosis at any one of these 3 points. So here comes the role of a pre-curved IUI catheter. So that straight IUI catheter, while it might work in 4 out of 5, in 1 out of 5, you would want a curved IUI catheter. It's either a curved catheter or a catheter which can be bent and it has memory. And some of these will also come with a stylet in order to make it a little more firm while you go through the cervical canal. So the cost of this is, of course, a little more, much more in fact. If the straight cannula was 150 upper limit, here you might find that the costs of these might be 600 to 700 rupees per cannula, but it doesn't hurt to keep about 2 or 3. So if you do about 100 IUIs in a month, you might need about 10 of these in your lab per month. So if it's a crypt, polyp, or false passage, trial and error might work. Ultrasound guidance is another in order to negotiate the false passage. And of course, if nothing is working, you might just have to abandon the procedure and take up the patient for a hysteroscopic correction later. There is this algorithm that we could follow if you are dealing with an acute anteversion or an acute anteflexion of the uterus. The algorithm, basically, I put it down as rebut OSH. Here first, and this is the more common thing that you will deal with, an acute angulation of the uterus with respect to the cervix, so that you can't cannulate at all. So you reposition from a low lithotomy or a standard lithotomy to a high lithotomy. This usually rotates the uterus backwards so that a very acutely anteflexed, anteverted uterus is slightly straightened in that sense. Bladder resistance, yes, that can straighten that angulation a little. Ultrasound guidance, once again, will help you. So you follow the endocervical canal and then you enter the uterus. Basically, you're doing you follow the canal through ultrasound. Tenaculum usage is in fact, there's something else in between. Now, if none of this is working, you're using your pre-curved cannula. The pre-curved cannula, sometimes you might need to use an obturator or a stylet in order to make it firmer or in order to make it conform to the angle of the cervix and the uterus. And if this doesn't work, only then you bring in the tenaculum. Tenaculum is so that now you are holding the cervix. At this point, you have made it a little uncomfortable for the patient, but then of course, at all times, gently doing the procedure, gently talking to her all the time helps. And informing her of what you're doing. And if this hasn't worked, then sounding to know the exact direction, retroverted, anteverted, left or right tilt. And of course, if none of this has worked, that you're dealing perhaps with a stenosis or something that you can't negotiate, then maybe you'll have to take her up for hysteroscopy. So I hope this one works. And this procedure basically demonstrates all the 5 points that I've mentioned in the past. So you can see here the cannula, you can see the angulation is extreme. This is where the speculum is, and this is where the uterus is. So although we try to insert, nothing is going in. This is where it is stuck. So this is the point at which you need to maybe use the first try with the pre-curved cannula. So we'll see that very soon. Now we are in fact using the Cook's transfer catheter here. And so even the curved cannula did not go. So we are now using the stylet to straighten it, to curve it a little more. You can see that the curve has been increased. And now we are trying to cannulate. And let's see where the tip can be seen. In this case, you can see very slowly there will be at some point, you'll see that this has negotiated the internal os and it has reached this point here. This is the outer catheter. It has reached there. You can also see that this is an adenomyotic bulky uterus. And beyond that, of course, we've used the inner catheter to now transfer the inseminate into the uterus. You can see it going in here, and Finally, you'd see that it's a very small volume that is being transferred finally inside. So you can see that ultrasound guidance has been used here, a repositioning, which was not a more extended lithotomy was used. Then we had to use the obturator as well. You can see that the bladder is full, and where we have used all the 7 steps that were mentioned in the previous slide. So this is another difficult procedure that we came across. Now, this lady had had a hip replacement on account of she was a progressive case of rheumatoid arthritis, and you'll see at some point that she has finger deformity. So in fact, it was so difficult for her. You can see that the space is so narrow, the 2 hands are barely able to go in. And we have, so the sister is of course trying to assist, but we had to stop her, that you might hurt her more. So this, we have had to use the sim speculum, we have had to use the valsalum in order to pull down the cervix. You can see that her hand here, there you can see her, the deformity in her hand. And in the background is also the anesthetist, who has in fact administered anesthesia in this case, because with this deformity, which meant that she couldn't flex or abduct her thighs, it was also not possible for her to consummate her marriage. So this is a case of IUI, which is being done under anesthesia. So having seen these videos, what are the questions? Do we need ultrasound guidance as a routine in all cases? Well, whatever studies we have seem to suggest no, not as a routine, but in difficult cases, it might make a difference. In routine cases, it will not make a difference in clinical pregnancy rates and nor in the patient comfort rate. So you don't really need an ultrasound guidance in routine cases. What about soft versus firm IUI catheters? And although I do remember from the first talk in our lecture by Dr. Ghulam Bahadur, who did mention that soft catheters might have a role over, what the Cochrane Review 2010, and as far as I know, there haven't been any other after this, that soft catheters don't really matter. And soft catheters are the ones which have a floppy tip that enters exactly like your embryo transfer catheter, except that the hole at the end, it's not a single expulsion end. You have 2 eyes at the on the sides, which allows semen to disperse from the cannula. So you can see that it doesn't really make a difference. So you could easily use your firm catheter, the straight ones to begin with, and if that is not working, the curved or the pre-curved ones. So finally, do we have a word on this? Will it impact pregnancy rates? And this has also been said amply today, that IUI is much more forgiving than embryo transfer. And this is, we kind of understand this, don't we? Because you are instilling semen at a time which is still 5 to 6 days away from implantation. So even though there has been cramping, there has been bleeding, there has been a lot of manipulation, and there has been a little bit of maybe uterine contraction, there is still some sperm that will make its way into the site of fertilization and be able to fertilize it. So it doesn't really make a difference. However, it makes a difference to patient comfort, which according to me should be one major issue governing how you do your IUIs. And of course, it makes a difference to how easily you will be able to do it. So with this, I end my talk. Thank you.
Wonderful presentation, Ruma. Really loved
Thank you,
it.
Ruma.
Thank you. Thank you.
And I still can remember that patient, that for anesthesia, 3 actually head molds had to be put because they could not even extend her neck.
Yeah.
The patient with the rheumatoid arthritis.
Yeah. However, she's pregnant. That's the good news, right?
Yeah, she's pregnant.
Let's hope she's able to carry her pregnancy through. Well, yeah, that will be the bottom line.
So a very nice presentation. I must congratulate you on that, Dr. Ruma. Very nicely made videos, very demonstrative for everybody to, pick up points. Just to reiterate, just that, yes, you've said very nicely how commonly we encounter the position, the importance of position cannot be undermined. Talking of, yes, flexing the legs, using a good catheter. Yes, we do use curved catheters, although very rarely, but they can be done. A good clinical examination just before an IUI can actually help us to aim the catheter towards whichever direction, whether it's an anteverted uterus or a retroverted uterus. And yes, you have taken care of all the points.
Dr. Ruma, did you come across a point? I want you to tell that where you are in the OPD, you cannot get the patient back somewhere. You have to do something, and you just land up doing an intracervical insemination because at that point of time, you cannot do anything more than that.
Yes, yes. So yes, I mean, yes, no, so my point is that if you anticipate, and this might happen, like I said, maybe not in 1 out of 5, but maybe 1 out of 6, it's best to do it in the IUI room is what I would suggest. So I'm not very comfortable personally doing it in the OPD because I know I can't position her in case of a difficulty and things might then, and I won't have access to the curved catheters, which we do in the laboratory. Yeah.
Have you done any IUI in the knee chest position?
I personally haven't, but I've seen some of you do it.
Yeah.
I've seen you and I've seen Dr. Abha do it. And in fact, so she did instruct me on how it helps in, again, straightening the axis, an extremely, let's say a retroverted uterus, if you're suspecting if it's an extremely retroflexed uterus, a knee chest position or even a lateral decubitus position can sometimes help these patients.
Dr. Gaurav, if there is a traumatic semen collection and there is blood, evident blood in the semen, how do you proceed?
In case of normozoospermia, you'd first want to do a direct swim up, and that will help in separating the motile sperm from the RBCs, because unfortunately a density gradient does not filter out RBCs.
Okay.
So, or otherwise one can use a erythrocyte lysate buffer if that is available in a laboratory, and that generally we use to get rid of the blood cells in testicular sperm samples which are during aspiration. So that is very useful.
Gaurav, I have one more question. Suppose when we've been hearing a lot about second ejaculate. So suppose the first ejaculate volume is 2 cc and which has very low count and motility. So you ask the male partner to have a second semen sample. Suppose that volume is 1.5 cc. Now the total volume is 3.5 cc. Will you mix both the sample or do you prepare them separately and you give a higher volume to inseminate? How do you go about preparing this sample?
See, if the second volume has 1.5 mils,
yeah,
then it will suffice on its own. But generally, that will not be the case.
Okay,
The second sample, the sample which is given immediately after, will have a minuscule volume of maybe 0.2 ml or
0.5 ml or something.
0.5 ml at the maximum.
Yeah.
So in that case, depending on if you want to mix it with the first sample, you can do the pooling, because then the volume becomes very small for an effective sperm separation. And you can pool both the samples. But in case there's enough volume in the second sample, then you can just go ahead and separate the sperm.
So you would not prepare the sample with 0.5 volume even if it has a better count and motility?
Yeah,
you will still like to pool it with the first sample?
Yeah, we can combine. We generally combine both the samples because that works.
That works, okay. Because I've been thinking all through the workshop this question, so I wanted this to be addressed.
Here also, that a split ejaculate, always the first fraction is considered much better than the second ejaculate which comes. So if you have low counts, would you prefer to have a split ejaculate or you would want the person to have a double ejaculation?
A double ejaculation.
Ma'am, can I answer this question of yours?
Yeah, sure.
So what you are referring to is the first ejaculate of first part of the first ejaculate. And what we are talking about is a second ejaculate as a separate ejaculate, which is lower in volume and but better in quantity.
The split ejaculate doesn't change the ejaculatory abstinence between the two parts.
Yeah. And that is why in a split ejaculate, the first ejaculate has the highest concentration of sperms in a split one, which is ejaculated at the same time, but two ejaculates.
But two bottles. But second ejaculate.
The second ejaculate will have a better motility and
Morphology also.
as compared to
One
the
more
first.
point I wanted to make
Morphology
about,
also.
about the reason where we use um, um, we don't use a lithotomy, but we use a knee chest position for
Yes.
IUI, and that is when the cervix is pulled up right behind the symphysis pubis. Whether the uterus is anteverted or retroverted doesn't matter, because it depends on the surgical procedure which has been done, and that is how either the bladder is stuck to the anterior wall and therefore the cervix is pulled up, or the uterus has stuck absolutely retroverted and the cervix has gone high up. In both these instances, a knee chest position helps in being able to visualize the cervix and put in a catheter. So this is extremely helpful in some of my patients where they had consecutive
Yes.
pregnancies only in this position and nowhere else, because even normal intercourse doesn't deposit semen in a cervix which is pulled up on the anterior fornix behind the pubic symphysis.
So can we wind up the conference and I can just give some take-home messages?
Yes.
Can we do that? Okay, thank you everyone for attending it. I think we had over 400 delegates remaining till the end to listen. Very few pointers. In 2 minutes, I'll wind up. Number one, we emphasized in this workshop is the importance of two follicles in unexplained infertility, not in PCO group, but in unexplained infertility. So your stimulation protocols have to be catered in such a way that if you can increase your follicle from 1 to 2, but not at the expense of high order multiple pregnancy. So you should have a very strict cancellation criteria too. Then we heard was that the size, which every time I hear in a clomiphene 20 millimeter, in a gonadotropin cycle 18 millimeter is good enough. Emphasis was given on double IUI in certain cases, consecutive ejaculate we just discussed, optimal thickness of endometrial lining. Then we also gathered the same thing, that whether it is urinary, HMG, FSH or recombinant, though the recombinant, the possibility would be that you would be landing up using lesser dose, but it is same. You could add oral ovulogens to gonadotropins to optimize your stimulation. Then we saw that no role of antagonist, absolutely not in PCO group, maybe in non-PCO, but more so to overcome your weekend issues, but generally not adding because it would add up to the cost. LH surge, not routinely required because the cases of premature LH surge are very low. So we don't need to couple so many ultrasounds, so many LH surges. There is no need as such for documented ovulation. If you have given an HCG, ask the couple to have natural intercourse for sure during the cycle. Do not make them abstain. Shorter duration of abstinence. No need to document ovulation. You can plan your IUI at this time you have decided, which could be anything between 36 to 48 hours post HCG. There is no need to repeat the HCG. There is no need to do an IUI later than that, because after that, the eggs are already post-mature and the pregnancy will not happen. Then we moved on to the medical legal aspects. Dr. Tanya very nicely said that what consent forms you need, and especially when you're dealing with very special situations like cancer preservation, single men, married, cancer therapy is very important. Donor IUIs, your normal IUIs first. Straighten up your normal IUI cycles and lab practices. In luteal phase defect, we only heard that, the take-home message is that give a luteal phase support in gonadotropin cycles. In simple cycles, we don't need them. And Gaurav very nicely explained, and then Ruma very nicely showed the procedure of IUI and how to tackle difficult IUI. So we are coming to a summing up of this conference. The next, I'm still inviting as, the core member of Indian Fertility Society to attend Fertivision. And I and Dr. Neeru and I would be doing a workshop on OPU and ET. So moving on from IUI, if the delegates are interested, please attend that too. Now I'm handing over to Dr. Neeti for the vote of thanks.
It is indeed an honor to deliver vote of thanks to the esteemed faculty of this workshop who spared time from their busy schedules to share their knowledge and experience with us. I would also like to thank our dear delegates who joined us in big numbers today to make this workshop a great success. My sincere gratitude to Dr. Abha Majumdar for her guidance all the while, and Dr. Shweta Mittal, the convener, and Dr. Kavita Agarwal, my co-convener, for organizing this workshop with me. We are really grateful to Mr. Sumit He's almost doctor now. He's listening to all the workshops all the while. He's almost doctor. So Mr. Sumit and his team for the perfect back-end support. And in the end, last but not the least, I would like to thank our sponsors, Merck Serono and Intas Pharmaceutical, for all their support. They're always there to help us.
And a special thanks to Dr. Kocher, who's always giving us blessings. She's always there. She's enthusiastically attending. So thank you, ma'am, if you are attending this program. Dr. Neeru wanted to say something, and Sumit, you have to give us a round of applause for finishing on time this workshop.
Yeah,
Absolutely by the minute.
Yeah. Can I have a small announcement, please? Neeti, can I have a small announcement?
Yes, Dr.
It's
Neeru.
my pleasure to invite everyone for the 16th annual conference Fertivision. It's the first virtual and first the global conference where we have more than 50 international speakers and 10 workshops. So all the workshops are complimentary, and moreover, this workshops and conference, these are free for the IFS members. So those who are not the member, please become the member before 25th of November. But all IFS members have to fill the form before 25th November. So again, we are meeting on 29th with Dr. Shweta and me. We are doing ovum pickup and embryo transfer workshop. Gaurav is also with us. So we have a lot of video. Please come and join conference on 4th and 6th December and workshop on 29th. Please come, and all IFS members fill the form. And it's a greater chance for non-members to become the membership even with the less than 3,500 rupees. Thank you.
Thank you, Dr. Ava, for being with us the whole day for the workshop and giving such valuable inputs.
It was interesting.
Okay.
It was
Ma'am,
nice.
do you want to say something before we say bye-bye?
I think IUI is there to stay, and it is for the gynecologist also who can do IUI. And since now the time frame has been made so easy that anywhere from 24 to 48 hours, whichever is a convenient time, with minimal monitoring, minimal testing, and even clomiphene citrate, it should work. The only thing is trigger is a very important point, because that demarcates your timing of IUI much better than the woman trying to do LH surge at home morning, evening for many, many days. One ultrasound and one trigger, following a clomiphene citrate cycle for our gynecologist, and for our infertility specialist, possibly I would suggest gonadotropin followed by ultrasound, trigger, and IUI, well-timed IUI. This should be the take-home message. It is a procedure to stay. It can be done with our normal gynecologist also, not practicing IVF and infertility only.
So Sumit, can we leave? Now we have revisited IUI in the era of IVF, and now we visit again in Fertivision the era of IVF.
Okay.
Thank you.
Okay. Thank you, everyone. Bye-bye.
Okay. Bye. Thank you, ma'am. Thank you, ma'am. Dr.
Thank
Ava, ma'am.
Thank you. Bye-bye.
Bye-bye, Dr. Neeru. Bye-bye.
Bye.
Dr. Mamta, bye. Dr. Tanya, thank you for staying.
Yeah, 3 cheers for Shweta. Very nice.
Thank you so much.
Yeah, and
The
Neeti
teamwork.
also. Yeah, and all ALGT team. It's good to meet Dr. Mala also.
What makes me and Dr. Neeti very happy is that we maintain the time. That is giving us like the major happiness. Okay, bye-bye.
Cheers. Good.
Okay, Neeru. Bye-bye. Bye, Dr. Shalini.
Bye.
Bye, Dr.
Congratulations.
Piki. Thank you.
Bye. Bye.